Good morning to you all. I am Dr. Vijay, provincial representative of College Pediatrician. First of all, on behalf of Eastern Province, I would like to thank our college, Sri Lanka College of Pediatricians, especially Professor Shaman Indrajit and Secretary, and Professor Guani elected president, to provide this opportunity to this region. And also, unfortunately, Professor Shaman Indrajit, pediatrician, is unable to attend that program. So instead of that, Madam Professor Guani will present the welcome message. Thank you.
Thank you, Vijay. Good morning to everybody on behalf of Sri Lanka College of Pediatricians. I'm glad to say that we are here at the second virtual conference in the recent past. And 2 to 3 years back, we couldn't have kind of thought about this, conducting regional sessions the way we are conducting now. It's all because of, I think, amazing technology, and most importantly, I think SLCP is under the guidance of Professor Shyam and Rajendra, the incumbent president, is getting adapted to the new normal. So here today in the program, there are very important lectures which are lined up, and very importantly, there are very excellent resource persons who will be doing all these sessions, and hope everybody will be able to widen their horizons and give the best possible care for the children in our country. And I must say it's thankful to the organizing committee, specifically Dr. Vijay Lakshmi and Dr. Chandra De Silva for doing a wonderful job organizing these regional sessions, which is something in need during a pandemic like this. Thank you, and over to you, Vijay.
Thank you, Madam.
Thank you, Madam. Good morning to you all. I'm Dr. Roshant, acting consultant pediatrician at Base Hospital, Kalmara North. I would like to introduce our first speaker. She is Dr. Tekla Jayavikrama, consultant pediatrician, General Hospital, Ampara. She will now speak to us on investigating a child with developmental delay. Over to you, Dr. Tekla. I think you have to unmute, Dr. Tekla.
I hope you can see my slides.
Yes, Dr. Tekla, we can see and hear you. Yeah.
Right. So the topic is on investigating a child with developmental delay. For next half an hour time, I will talk about the assessment and investigate of a child with developmental. So, as the introduction, the developmental disorders remain a common presentation in children of 5 years of age. Early detection as well as interventions improve the outcomes. Therefore, considering developmental evaluation of every child. So, history and most crucial part in the child experiences and their effects lead to acquired developmental disorders. Genetic testing, neuroimaging, and metabolic testing newly developed areas lead to and more accurate diagnosis. Process which takes a child plus infant to self-sufficient adult. Developmental process is in a sequence manner. There are 4 main domains in the development: gross motor, speech, and social and self-care skills. So, developmental delay affects 3% of children under 5 years of age, according to UK statistics. This delay or normal in
Dr. Tekla, I think you are muted again. Can you unmute? Okay.
sorry about that. So sorry about the problem. So the developmental delay present with delay or abnormal development in 2 or more domains, which is called global, or affecting 1 domain, which is called this can mild, moderate, and severe. So developmental delay to stand mean process using standard development. Intellectual disability tends to be reserved for children over age of 5. So developmental delay can be divided into genetic, again metabolic and non-metabolic, and acquired. So the presentation of developmental delay, actually developmental delay that can be raised by parents, carers, or primary care professionals. If the child has not reached a specific milestone at certain ages, reach a plateau of development, or acquired skills are lost, which is called developmental regressions. Those are the concerns raised by parents, carers, or primary care professionals. So, especially premature babies, children with hypoxic ischemic encephalopathy, especially newborn period, and children with sensory impairment are at special risk. Therefore, every healthcare encounter should be an opportunity to inquire about the development of a child. Actually, we assess a child with mild delay 1 way, so watchful waiting and to ensure progress is sufficient. So sometimes physiotherapy, speech and language therapy is also helpful. Health visitors can provide parenting support and health promotion, but not to forget about the significance of sensory impairment, speech delay, and fine motor delay. If they are there, a hearing screen as well as ophthalmologic assessment is essential. So if there are red flags, which I will discuss in next few slides, as well as regression or moderate severe delay over a range of domains, should be referred to secondary care for further investigation. So, in the history, some clues might direct towards a genetic or acquired cause, especially natal history, maternal infections, alcohol, and drug use, exposure to toxins, and fetal concerns are really important. It is also an important question about labor, delivery, and neonatal history to detect antenatal or perinatal risk factors. We have full development when specific milestones reach and progression and any signs of regression. In history, family history is really important about developmental difficulties and other neurodevelopmental disorders. Not only that, history of recurrent miscarriages, unexpected deaths in the family, especially infant and young children, parental consanguinity, they're all important and could point towards a genetic disorder. Social history and concerns in form of trauma, neglect, and domestic violence could cause attachment difficulties leading to developmental issues. In depression can cause a significant impact on the developing child. Then, the most importantly, we'll just see what are those red flags which we discussed earlier. So, presence of red flag is disorder development and require immediate referral to a pediatrician. Also, at any age, the loss of development is or regression. No professional concern about visual impairment, fixing, or follow. Hearing loss or not responding sounds. Head circumferences more than 99 centile or less than 0.4 centile or rapid changing is crossing 2 centiles. Abnormal muscle tone, hypo or hypertonia, or any asymmetry in involvement. They are at any age considered as red flags. So age-specific red flags are there also. So no social by 6 to 8 weeks, primitive reflexes at 6 to 8 months, waiting for objects by 6 months, not sitting unsupported by 12 months, not words by 18 months. So they all are age-specific red flags. So other age-specific red flags are cast at 18 months, not walking independently by 18 months, persistent or walking, have preference before the age of 2 years, not sharing interest by 2 years, not running by 2.5 years of age. They all need immediate referral to a pediatrician. Examination, the height and weight are really important to assess nutritional status. Head circumference to assess micro or macrocephaly. Dysmorphic features are important to detect any children. Neurocutaneous stigmata are important to detect neurological abnormalities. Cardiovascular abdominal examination are important to rule out comorbidity, metabolic or storage disorders. Examination is essential. Focal neurology or asymmetry can be indicative of potential etiology. Examination vision is important. We particularly have to look at reflex cataract. If there is any doubt about vision or hearing, So referral to audiology and ophthalmology services are essential. So how do we assess development? So specific developmental milestones are there, and developmental assessment tools are developed to determine child's current stage and motor developmental progress. The common tools are age and stage questionnaires and schedule of growing skills. More detailed assessment tools are available, such as Griffiths and Bailey scales, which but require specialist training and highly time consuming. So developmental regression. So when we talk about developmental delay, so the urgent referral is needed in children with developmental regression also. Developmental regression means progressive deterioration for more than 3 months of loss of already acquired developmental abilities and abnormal neurological signs. This suggests serious underlying pathology. It can be neurological, neurodegenerative, and neurometabolic disorders. Many of these are incurable, but treatment exists for some which might hold or slow the progression. So, copper injection for meninges, kinky hair, and chelation therapy in Wilson disease. Therefore, any child with suspected regression, urgent referral to pediatric neurologist is essential. When we talk about development delay, so in the modern society, adverse childhood experiences are more common. The researchers have found the more adverse childhood experiences exposed to, more experience who are in adults. So these experiences tend to lead to delayed development. So this can be considered as an important acquired cause of developmental delay. So now let's move to investigating developmental delay. Though the investigations are there, history and examination is the crucial part, because 1/3 of patients can be accurately diagnosed alone. 1/3 can be diagnosed following targeted clinical assessment. Not all children present with developmental delay require investigation. Mild delay or adverse childhood experiences significantly contribute to the presentation. A period of watchful waiting is accepted. Experiences, childhood experiences, prevent worse outcomes later in life. Children with abnormal neurology, dysmorphic features, microcephaly, and prenatal and perinatal events, the yield of investigation is significantly increased. So when we consider genetic testing, the of investigation nowadays. So genetic diagnosis can help with condition-specific management as well as some prognosis, about pregnancies, as well as give families a sense of closure and acceptance of their child's condition. All parents are counseled before the test because diagnosis could be found upon that abnormalities of unknown significance and unrelated abnormalities can be found. They can have implications for the pregnancies and the child in the future. Not only that, like some cultural and religious societies have stigma on the diagnosis. Therefore, all parents need to be counseled before genetic testing. So, is the first line investigation in genetic testing. Chromosome microarray. So, array-based comparative genomic hybridization, ACH. So, if no cost can be found by examination alone, this chromosomal microarray is indicated. It has detecting small deletions and duplications, such as small deletion and duplications. So if a normal CEG microarray and still have a concern about genetic disorder, so we have to refer the patient to a clinical geneticist. They have whole exome genomic sequences and advanced genetic assessment and can increase the yield. So genetic are fluorescent in situ hybridization of fish. So multiple ligation dependent probe amplification, they all are when the specific condition are suspected, such as like deletions in 22q deletion or fragile X syndrome. The results are quicker than required. Actually, fragile X remains a routine first-line investigation in all children with moderate to severe developmental delay. So when you move to metabolic blood investigations, as first-line investigations, genetics to discuss microarray and fragile X under genetics and blood test, creatine kinase, blood count and lead levels, they are like pickup. As well as urinary organic acid is indicated as first line investigations. Second line investigations, genetic test, metabolic test, the blood for homocysteine for so glycans, aminoglycans, and oligosaccharides also. Electrophysiology, second line investigations. So when we consider biochemical blood test, so of metabolism, in our country we do congenital in the country, but in certain other countries like UK, they test for several diseases. So in the UK, in metabolism are detected, betonuria, medium acid coenzyme deficiency, Creutzfeldt disease, isovaleric acidemia, homocystinuria, and congenital hypertension. So, biochemical lactate and ammonia are commonly used as blood test. Lactate usually detect energy metabolism disorders, and CSF lactate is more accurate, but it's invasive. When we consider ammonia, so it can detect urea cycle, liver disease, or other disorders of metabolism. Can be taken when interpreting blood for both blood lactate and ammonia as chronic excessive arm tourniquet, and hemolysis can lead to mild increment of lactate and ammonia. So when we consider plasma amino acid and urine organic acids, though we do those, their yield is often poor. Urinary glycosaminoglycans can be used to treat autism, cause facial pace, and younger children only with developmental delay. Creatine kinase, so when gross motor and speech delay is there, to detect muscular dystrophies. For hypothyroidism as well as iron deficiency, and hypothyroidism can in children, common in children with Down syndrome and Digital syndrome. Neuroimaging, actually the neuroimaging in developmentally is the MRI version. Is increase in neurological abnormalities. The advantage is no radiation, but younger children are likely to require general anesthesia. Therefore, risk versus benefit should be measured. So, in future, functional imaging may play a role of children with developmental delay. When we consider neurophysiology, EEG not considered as first line, so it is reserved for children associated with seizure or feature of neurodegenerative conditions. Syndrome, which is has characteristic EEG findings. EEG is not used routinely except in children with suspected neuromuscular disorders. So it is usually carried out in conjunction with specialist pediatric neurologist. So when we talk about the last part, actually we should focus on maximizing the child's developmental potential. In most cases, curative treatment will not be available. Multidisciplinary team approach is essential of the child and family at the center of care. Pediatricians are only one part of the team. Physiotherapy, occupational therapy, speech and language therapy play a vital role. Always we have to close link with educational services, even at a younger age. So this is multidisciplinary. So health risk in community support programs and social care involvement will be crucial in children experiences adverse childhood experiences such as abuse, domestic violence, and substance misuse. So I just summarize what I in slides. Disorder remain a common concentration in children under 5 years of age. Early detection and interventions invariably improve outcome. The lot of researchers show childhood development assessment should be out as part of a holistic assessment in every healthcare encounter. Development facts, we have to keep that in mind. Urgent referral and assessment should be great. So nowadays, genetic investigations and gene involvement in development increase the diagnostic yield. So they are like a lot of our developmental delay, we tend to have a diagnosis now. So we have to keep in mind the impact of experiences and trauma on childhood developmental and have acquired developmental delay. So that was basically about assessing and investigating childhood developmental delay. Thank you for listening.
Thank you, Dr. Tekla. I think we can keep the questions to the end of the sessions. Our next speaker is Dr. W.A.M. Aslam, consultant pediatrician at Ashraf Memorial Hospital, Kalmune. He will talk to us on management of childhood pneumonia. Over to you, Dr. Aslam.
So I am not able to share my screen, please. Please allow. Hello, good morning. Good morning, everyone. Can you see the shares, please?
Yeah, good morning. We can see Dr. Aslam.
Okay, very good morning. I'm Dr. Aslam from Kalmay Hospital. I'm briefly explain the pediatric pneumonia in view of diagnosis, investigation, and treatment, where we can utilize in the peripheral hospitals. Okay. So when we come to pneumonia in children, community acquired pneumonia is one of the leading presentations to the hospitals everywhere. And this is one of the leading cause of death under 5 years of age. And out of this, most of them are viral pneumonias. But there is a certain percentage of pneumonias caused by bacteria, which cause this most of the deaths. But vaccination is one of the very effective methods which prevent this death from pneumonia. In fact, UK has shown there is marked reduction in death due to pneumonia after the initiation of the vaccination program. And at the same time, pneumonia has a marked seasonal change as well, basically because most of the pneumonias are due to viruses, and viruses behave seasonal pattern, and there is a wide marked change in the seasonal pattern as well. So when we want to know what is pneumonia, there is no single definition which is universally accepted to define pneumonia. But it is an infection in the lower respiratory tract, mainly involving the bronchi and alveoli, in which there is accumulation of the fluid in the air spaces, which obstruct the air passage, oxygen and carbon dioxide transport, and which will lead to the common symptoms of pneumonia like cough, sputum production, fever, and breathlessness. And in the pathological specimen, we go when we do the pathological specimens in pneumonia, there are 4 stages in which the initial stage is congestion, where you see this congestion and edema in the lung tissue, which is usually a transient period, maybe about 12 hours to one day duration. After 2 to 4 days duration, there is accumulation of fluid, which involve red cells and exudates, which appear as red. And after that, there is degradation, which causes gray color, and this is go as gray hepatization, which will last for about up to 7 days, and there is a resolution period of about 3 weeks. And we can categorize pneumonia with radiological appearance as well. First of all, it is bronchopneumonia, where you have patchy consolidation all over the lung fields. And then you have the lobar pneumonia, where there is a larger continuous consolidation of an entire lobe within the lung. So if you see this X-ray, the left upper lobe is consolidated. And there is another radiological classification, which is round pneumonia. This is a phenomenon in children whereby there is well circumcised round shape opacity. Usually this is in the lower lobes. And when come to the causative organisms of the pneumonia, so it's most commonly it is caused by viral pathogens. Out of them, the respiratory syncytial virus is the commonest, and rhinovirus, influenza, parainfluenza, and human metapneumovirus are pathogens. But nowadays, what we see is coronavirus has taken the place, and most of the viral pneumonias become coronavirus have a wide percentage of pneumonias. And when we see these immunosuppressed patients, we have to consider cytomegalovirus as a causative organism. And when out of these pneumonias, bacteria also have a certain percentage of pneumonias. And these are the bacteria are the organisms which cause severe diseases and which responsible for up to 64% of pneumonia related deaths. Globally, streptococcal pneumonia and Haemophilus influenza are the most common bacterial pathogens which cause common community acquired pneumonias. And there are atypical pneumonias which are caused by Mycoplasma and Chlamydia. These are, percentage wise, these are very less, but it accounts 27 to 30% of bacterial pneumonias which admitted to the hospital. Basically because most of the community acquired pneumonias, if they are failed to respond to first line treatment, they get admitted. So because of this admissions, the amount of atypical pneumonias in the hospital admissions is very high. The atypical pneumonias are caused by organisms which are difficult to detect in the traditional gram stain and culture methods. And rarely we need to consider tuberculosis as one of the causative organisms, especially when we come across traveling children from travel areas and immigrants from areas with high rate of tuberculosis. And fungus is also particularly important when we can have patients with immunosuppressed patients, especially in HIV. Funguses play a major role in causing pneumonia. Out of that, pneumocystis jirovecii is one of the commonest pathogen. So when we consider the causes with the age, if it is less than 20 days babies, commonest bacteria are E. coli, group B streptococcus and listeria. Out of this, listeria is more common in preterm babies. And if the babies, if newborn babies, if they have become preterm, born with meconium, we especially suspect listeria. And if it is 3 weeks to 3 months, in all ages, streptococcus pneumonia is one of the commonest organisms. And in bigger infants and children, Mycoplasma also play a major role. So up to 3 months, other organisms like Chlamydia, Haemophilus influenza, Moraxella catarrhalis also take a major part. And after 4 months, Staphylococcus aureus also become a main causative organism as a bacterial pneumonia. When we consider the viruses, in less than 3-month-old, herpes simplex virus is one of the commonest organism. And other than that, cytomegalovirus, adenovirus, respiratory syncytial virus, and other viruses are we see as causative organisms. Likewise, after 4 months also, you see adenovirus, the common viruses cause infection. And at the same time, after 4 months, varicella zoster is one of the causative organism as viral pneumonias. So when we come to the presentation, how the children present with pneumonia, the symptoms of pneumonia usually are non-specific. And the symptoms, vary widely with the age as well. The commonest presenting features include fever, cough, rhinorrhea, dyspnea, and lethargy as well. In small infant, they are presenting symptoms may be reduced feeding, and they present with grunting and apnea as well. If these children, very small infant presenting with these features, we have to consider in our mind pneumonia as a causative organism. Conversely, in older children, some of the commonest presentations are breathlessness. Some of the time they present with pleuritic type chest pain. And one of the common presentation is abdominal pain as well. In lower lobar pneumonia in bigger children, they present with abdominal pain. And very rarely, children with pneumonia can present with headache as well. So when we come to the signs of the pneumonia, usually there is reduced breath sounds with the lobar pneumonias, and you can hear crepitations as well. And focal crepitations are the salient feature of pneumonia. And tachypnea and hypoxemia have a high sensitivity of predicting a pneumonia. And this is very important in deciding whether the child can be managed in the community or whether we need to admit the child as well. And if the child have wheeze and a low grade fever, that typically it's not a pneumonia. And in the examination, the clinician should pay attention for the percussion note as well. A dull percussion note alone will be the presentation of lobar pneumonia in some of the times. And in the percussion, if there is a stony dull note, the clinician should think of complications of the pneumonia. It's possibly due to a pleural effusion or a empyema. So when we consider about investigations, there are no specific investigations recommended for children to diagnose pneumonia, where we can manage these patients in the community. But for the patients who require secondary care assessment or hospital admissions, they might need microbiological or imaging or blood investigations. So when we come to the microbiological tests in relation to patients whom we are admitting to an institution, sputum, gram stain, and culture is the most important investigations, which will help to detect the underlying bacteria which cause these organisms, and you can get the sensitivity pattern as well, which will help to treat with the specific investigations, specific treatment. But it is very difficult to take this sample from young children. And the other point is, it takes several days to get a culture report. This test is very useful in severely unwell children and the children who are not responding to the treatment. So in these children, we can do the culture report where we can get the sensitivity and pattern, and we can target with the antibiotic treatment. And it is very useful in intensive care unit children as well. In the intensive care unit, you can, they used to do bronchoalveolar lavage to get these samples. In small children, if you want to do a gram stain because they won't produce the sputum, you can do a early morning gastric aspirate to detect the cultures. And one of the other microbiological tests is nasopharyngeal aspirate. This is useful in viral detection. We can do the viral polymerase chain reaction. This is very useful during this corona pandemic. But use of bacterial detection with the nasopharyngeal aspirate is very less, basically because of the oral colonization of the bacteria. And now the newer tests like rapid detection of the capsular polysaccharide antigen of this streptococcal pneumonia from the urine samples are very high sensitive, but their low specificity reduces its clinical utility. So when we come to the imaging, the British Thoracic Society guidelines do not recommend routine radiograph for pneumonia, basically because pneumonia is a clinical diagnosis and radiograph will not change the management. Depend on the clinical situation, we decide whether to admit or not, what antibiotic to treat, and depend on the sputum cultures we decide. So it won't warrant, it won't change the management. and also the interpretation also subjective. But chest X-ray do play a role when complications of pneumonia are suspected. And at the same time, chest X-ray should be considered where symptoms are persistent and where there is inadequate response to treatment within 12 hours. For example, now in the district hospitals and other places, when you treat with pneumonia, if the patient is not responding, you should do an X-ray. Or else, if you don't have the facilities, you transfer the patient to a place where the X-ray facilities are available. So when we come to the blood test, British Thoracic Society suggests not to do acute phase reactions to differentiate between virus and bacterial infections, because both of these diseases can raise the CRP level. CRP also useful when we suspect complications, and when we have a patient with complex disease where the patient is the child is not improving with existing treatment. So you can monitor the CRP level to increase or upgrade the treatment modalities. At the same time, white cell count or erythrocyte sedimentary ESR will not differentiate between viral and bacterial etiologies. Procalcitonin, which is also acute phase protein, which is not raised by viruses or collagen vascular diseases, but it is very sensitive for bacterial infections. So there are a lot of research evidence which suggests it could be used to guide the treatment with antibiotics. But the procalcitonin results not freely available in the government sector. At the same time, it is very costly in the private sector. So when we come to the management depends on an assessment of the severity. So depend on the severity, whether the child needs oxygenation or IV fluids, we need to decide the management. And at the same time, associated risk factors. If the child is having chronic disease or other, child with asthma, background history of asthma, they are considered as risk factors, and you need to escalate the treatment. And social background of the child also very important when we consider about the management. And when we come across with children with complex needs and chronic underlying lung conditions, so chronic lung disease, and as I told you, asthma and cystic fibrosis, these kind of children, we have to consider these factors as well when we come to the management. So when we decide the severity, so if the infants or older, if the temperature is less than 38.5, with the respiratory rate of 50 breaths per minute, with mild recessions or mild breathlessness, and if they are taking feeds without vomiting, it is considered as mild to moderate. These categories, if the child is okay, we can manage in the community as well. But if the child is having very high temperature and respiratory rate more than 70 breath minutes and severe recessions, these will indicate child need admission to an institution, especially if the child is developing cyanosis, apnea, and signs of dehydration with prolonged capillary refilling time. These are features which suggest child might need intense monitoring. So these children may need HDU monitoring. So when we come to the hospital admission, oxygen saturation is one of the vital parameter which suggests whether the child is need hospital admission or not. So if the saturation is less than 92, better the child admitted to a hospital for vital monitoring. And at the same time, tachypnea is one of the very good sign where you can decide whether the child need admission or not. So careful monitoring of the respiratory rate and counting the rate is vital important to decide whether the child we can manage at community level or we need to admit. And if the pneumonia is severe enough to cause respiratory failure, requiring ventilatory support, or when the pneumonia is complicated by septicemia, these children are admitted to a ICU or a HDU. So respiratory failure would be indicated by low partial pressure of oxygen or high partial pressure of carbon dioxide. And this indicates the child's need of respiratory support. These one need immediate referral to a high dependency unit. And children with septicemia may present as tachycardia, tachypnea, and severe hypoxemia and signs of shock or recurrent apnea. If the child is having irregular breathing, like abdominal breathing also, we need to consider HDU care or ICU care. So when we come to the treatment for pneumonia, the children who we are managing in the community, they need safety netting advices. That means we need to advise them on the signs which they need to consider immediate admissions. For example, if the child's respiratory rate is increasing, if the child feeding difficulty is increasing, and child is becoming breathless, cyanosis, we need to educate the parents on this. If these features are appearing, they need to immediately admit to the hospital. The main way of hospital treatment is supportive management. This involves immediate oxygen treatment when the oxygen saturation go below 92%. And if the child unable to feed and maintain the hydration due to the breathlessness, we need to give intravenous fluid or nasogastric tube feed to prevent the dehydration. When we give the intravenous fluid, we have to consider inappropriate antidiuretic hormone, SIADH as well. Because of that, we have to closely monitor the electrolyte levels, especially the sodium. And in the pneumonia, even though we practice chest physiotherapy, the British Society of Thoracic Society not recommending chest physiotherapy as a routine treatment for uncomplicated pneumonia. So sometimes some small children, they can't clear their airway due to these mucus secretions. These children need assisted airway clearance. And children who are acutely unwell, they need immediate antibiotic. So when you consider antibiotic, amoxicillin as the first line treatment, it has effective coverage against most common pathogens. If you have a local guideline antibiotic policy, depending on the sensitivity, you can adapt to that antibiotic pattern. We have to keep in mind enteral administration of antibiotic is as effective as intravenous. So intravenous antibiotic may require where complications are suspected or when the enteral route is poorly tolerated. If you are suspecting an atypical infection or the first line antibiotic are not responding, you can consider macrolide as antibiotic. You can use azithromycin or clarithromycin. Some of the institutions, they use amoxicillin and macrolide as a first line treatment. Comoxicillin may be a better first line antibiotic if the child have complex needs or poor cough or swallowing dysfunctions, or maybe if the child is malnourished, you can go for comoxicillin. So when we come to the complications, most children with community acquired pneumonia go on to make a full recovery without any complications. But pulmonary and systemic complications occur in around 3%, resulting in significant morbidity and mortality. The usual pulmonary complications include parapneumonic effusion, empyema, and lung abscesses. Systemic complications can include multi-organ failure, metastatic infection, bacteremia, and acute respiratory distress syndrome. If any physician who are managing these patients with complications better to transfer to a place where facilities are available rather than wait until it become mature disease. So regarding the follow-up, British Thoracic Society guideline do not recommend routine follow-up imaging in uncomplicated community-acquired pneumonia. If complications arise, such as empyema or persistent lobar collapse, then this may warrant follow-up X-rays. And round pneumonia, if it is responding to antibiotic, it quickly recovers where you do not require any follow-up radiograph. And future development, one of the future development is bedside ultrasound. Ultrasound is one of the best diagnostic tool currently used in many pediatric intensive care settings, which could reduce the need for radiation exposure and which reduce the need for chest X-ray. So the benefit of ultrasound include absence of radiation exposure, and it is economical as well. So when compared to the laboratory test, this is an interesting area for the research purposes as well. Use of blood specimen to identify a host transcriptional signature associated with specific pathogen. This is a genetic test. The ability to determine the causative organism quickly and effectively, which will allow antimicrobial treatment and duration of treatment to be guided more effectively. And identify the children at risk of severe disease and the development of complications also, we can utilize this. In time, pathogen signature may be used to discriminate between viral and bacterial causes via blood sampling. So in conclusion, pediatric pneumonia is a common but potentially very serious illness. The major challenges for the physician is in determining between the viral and bacterial etiology, improve antimicrobial stewardship, and recognize the unwell child who would require hospital admission for further management. Until more sensitive tests are available, physicians will continue to depend on their clinical acumen to make these difficult decisions. Thank you.
Thank you, Dr. Aslam. We will now proceed to our next speaker. He is Dr. Kavinda Dayasri, Senior Lecturer in Pediatrics at University of Kelaniya. He will speak to us on an approach to an intoxicated child. Over to you, Dr. Kavinda.
Dr. Ashant, can you see me?
Yeah, we can see you. Still, we can't see the presentation.
Slides. Okay.
Yeah.
Can you see my slides now?
Yeah. Yes.
Okay.
No, not yet.
Thank
Not
you.
yet. Wait.
Still not?
Yeah. Can you share again?
Yeah. Give me a second.
Yeah, we can see your desktop now.
Okay. Thank you very much. So thanks for those kind words of introduction. So today I'm going to talk about a practical approach to the poison child. So management of children who present with poisoning is often challenging, and this is due to several reasons. Compared to adults who come most of the time with a clear history and with a known history of what the ingested substances are, children often present with an unknown history of poisoning, and the poisoning event is often unwitnessed and it's unintentional. Therefore, the history is often vague. And also determining the ingestion time is difficult because we don't know what children have ingested and the time they have ingested. And for the same reason, determining the ingested dose, thereby predicting the risk of further toxicity, is often difficult in children. And it's also important to know that the circumstance of poisoning also usually change with the age. Most of the younger children present with accidental, whereas as the children grow up, they present with either accidental or non-accidental poisoning. And also with the body composition, the weight and the fat distribution of children, the toxicokinetics of this poison substance also change. So we know so the behavior of toxin may not be the same in each and every child compared to an adult with the same body size. And also certain ingestions may have a safeguarding concern. For example, a very young child coming with suspicious poisoning. And also because of the body weight and the body surface area reduction, in some cases, a few pills, even one pill or a couple of pills, can kill young infants with certain poisons. Therefore, we have to do the risk assessment based on the worst case scenario, where we anticipate symptoms or kind of a complicated course following the poisoning event. So let's look at the global epidemiology. So poisoning is still a common problem everywhere in the world, and it accounts for nearly 45,000 deaths every year in the world. It's caused, this is the data due to accidental poisoning, and there are a number of cases, like a number of children and teenagers who die following non-accidental poisoning as well. Therefore, these continue to be a significant cause of morbidity and mortality, according to the WHO, the recent most report published in 2008. If you look at the Sri Lankan context, kerosene oil is by far the most common poison. 2 decades ago, as well as currently, in both urban as well as in rural Sri Lanka, all the contribution made by that is on the decreasing trend because of the infrequent use of kerosene oil. And now we see a rising trend for poisoning with pharmaceutical agents as well as sanitary products because of their increased use. And plants and pesticides are still seen, but they are more common in rural regions compared to urban regions. Overall, poisoning in the pediatric age group is associated with lower mortality, which ranges from 0.4% to 0.7%. And also, if you look at the data, there have been notable reductions observed over time with regard to practice of harmful remedies by parents because of the increased public awareness as well as the education level of parents. So why children are susceptible to poisoning? There are two peaks of poisoning. One group is the younger children, toddlers, like children who are less than 4 or 5 years of age. And they ingest the poison mostly unintentionally within home. And most of these events are minimally toxic. And the incidence of these poisonings are largely determined by the availability of the poison within the household. And the predisposing factor is mostly the children's exploratory inquisitive behavior and the lack of sense of danger leading to unknowingly experimenting with these substances. Whereas in adults, you can see both intentionally as well as unintentionally. And this occurs mostly as part of deliberate self-harm, which is quite common in the teenage age group. And also there are like a fraction of teenagers who tend to experiment with illicit substances and recreational drugs and thereby getting poisoned. Let's look at the anatomical and physiological considerations when we talk about children. Why? The significant differences in terms of the effect of the toxin. So in children, as children grow up, the volume of distribution increases. This means like the drugs with a larger volume of distribution, they develop symptoms late in the older child. Indirectly, this means that an infant is likely to develop early symptoms as well as early toxicity following ingestion of the same dose. And the body surface area, the smaller children have a bigger body surface area, this can impact, like especially the topical application toxicities, for example, methyl salicylate. So the younger children can get more toxicity because they have less body water and larger body surface area. And skin, for the same reasons, especially the neonates who have a thinner skin compared to other children. Topical agents like methyl salicylate, dermal absorption is quicker as well as more, resulting in higher toxicity. And airway problems are more with children with smaller bronchi, smaller bronchial trees. So the toxins which can cause bronchoconstriction and secretions, for example, organophosphates, are seen more commonly in younger children. And ventilation, so younger children have a greater minute volume. Because of that, aerosolized toxins, inhalational toxins can have a higher toxicity in young children. And hepatic and renal, because they develop until a certain age, when they have immature renal functions or hepatic functions, eliminations can be delayed when the poisons are excreted through that pathway, and thereby we can see a higher toxicity. And breastfeeding, some of the toxins or some of the poisons can be secreted, for example, aspirin, cocaine, lithium. Therefore, even though child not have taken the poison, child can be indirectly poisoned because of the breastfeeding in some cases. And also there are certain like few poisons which we need to know. Even 1 or 2 pills can kill the child, especially a young infants. And these poisons include few categories: sodium channel blockers. So sodium channel blockers include tricyclic antidepressants and sodium channel blocking antiarrhythmics, beta blockers, and chloroquine. So they have very high toxicity even if you take 1 or 2 pills. And this is similarly seen with calcium channel blockers, which can cause severe, profound bradycardia and hypotension. So even if the child takes 1 tablet, it can be quite significant, and we need to monitor and manage very carefully in children who are presenting following ingestions of these tablets. And also opioids can result in respiratory arrest. Theophylline can result in cardiac arrhythmias. Amphetamines can cause severe cardiac arrhythmias. Sulfonylureas can cause profound hypoglycemia. Organophosphates can result in cholinergic toxidrome, and oleander can cause cardiac arrhythmia. So all of these agents, whether they are pills or not, even a small quantity can result in deadly consequences in the child. So what's the general approach we need to take in managing children? So for the same reasons I mentioned earlier, we have to manage considering the worst case scenario. So assume the time of ingestion as the latest time possible. And assume all agents that are unaccounted for missing were ingested. And spillage. So sometimes parents might say, you know, they saw some of the syrups were spilled everywhere, but it's very difficult. So you have to account for them, right? And then when more than 1 child is involved, like, you know, when 2 children together ingest a certain poison, then we have to assume that both children have ingested all the poisons. And also, if you are not sure, it's always good to consult the Poison Information Center. So it's very, very important to do an appropriate history taking and an appropriate physical examination in managing children with poisoning. So the main part of history taking includes doing a proper risk assessment. There are 5 components in this risk assessment. So first of all, we need to decide on what the agent is. There are many instances which are very difficult for us to determine what the agent was, because the poisoning event is often unwitnessed. So we can ask from parents or grandparents whether they are on any medication or whether they have had any medication at home stored. And also whether there are any tablets spilled or whether there are any missing tablets. So by that way, we can estimate if a child had ingested the poison or not. Or else if the child had been moving around in the garden, then we can ask whether there had been any poisonous plants grown in their gardens. And also, it's important to determine whether the tablets are standard release or extended release, because the pharmacokinetics can be different and the onset of toxicity are variable depending on whether they are standard release or extended release. And then determining dose, and then determining the time since ingestion. So if it's difficult to determine the time correctly, then always take the latest time as possible. And then assess the current clinical status. So see whether what symptoms the child developed following the poisoning event, whether they had vomiting, diarrhea, abdominal pain, and so on. And then look for specific toxidromic features, which I will be talking in a while. And also consider the patient factors, ask whether they have had any kidney malfunction, liver malfunction, body weight, age considerations, and whether they have had any past medical history, for example, psychiatric comorbidities, and so on, in taking the history. And then physical examination. So do the vital signs assessment. So assessing the blood pressure, pulse rate, temperature, oxygen saturation, and respiratory rate are vital in assessing any child with suspicious poisoning. And also determine the level of consciousness and assess the pupil size, and assess for skin signs, whether there had been profuse sweating or whether dry red skin are present. So these are important assessments in addition to the routine physical examination when examining a child with suspected poisoning. So observations are critical in evaluation of any child with any symptomatic child with poisoning. And they help us a lot to narrow down the differential diagnosis. For example, respiratory rate can be low or high, and depending on that, we can roughly estimate what the poisons were. So if the child's respiratory rate is low, the child is having bradyapnea or having irregular breathing, then we have to suspect agents such as benzodiazepines, opioids. And in contrast, if the child is tachypnic, then we have to suspect agents like stimulants, amphetamines, ecstasy drugs, salicylates, which can cause tachypnea, and toxic alcohol poisonings. And if you consider the heart rate, you can see a tachycardia in stimulant poisonings and anticholinergic poisonings like athanor or theophylline, or any like beta agonist poisonings. Whereas bradycardia is seen with beta blockers, calcium channel blockers, digoxin, organophosphates, and so on. And blood pressure can be severely low, like severe hypertension can be seen with agents such as tricyclics, beta blockers, calcium channel blockers. And in contrast, you may see high blood pressure when you ingest stimulants, especially the teenagers who present following ingestion of recreational drugs toxicity. And temperature is also quite helpful. If the child's temperature is high, it may be due to ingestion of agents such as cocaine, ecstasy, or salicylates, whereas hypothermia is seen with ingestion of agents such as barbiturates or alcohol. And consciousness can be low in children who present following opioid ingestions, benzodiazepine ingestions, or antihistamines such as Piriton overdoses, or oral hypoglycemic agent overdoses. And pupil size is also a very it's a very helpful sign. So pupils can be constricted in with agents such as organophosphates and opiates, whereas pupils can be dilated with agents such as atropine, athanor, tricyclics, and amphetamine. So if the child is having one of these signs, then they are quite useful in narrowing down the differential diagnosis. And we usually follow stepwise management in managing any child with significant poisoning. So first of the priority is given for resuscitation. So if the child's airways are compromised, then before any assessment, we need to secure child's airway. Or if the child's hemodynamics are deranged, then we have to fluid resuscitate and give inotropes and stabilize blood pressure and pulse rate before doing any other assessments. So after resuscitation, according to standard APLS protocols, then we can do a thorough risk assessment like I presented previously in a previous slide. And then after the resuscitation and risk assessment are over, then the next step would be to offer supportive care. And then we can do relevant investigations, but remember, investigations are not like we don't need to do a whole list of investigations. Most of the time, we can do the minimum number of investigations to manage patients. And then decontamination within the window of period, like where the decontamination is likely to be effective. And this can be followed by elimination techniques for poisons which are excreted through elimination techniques. And then there is a place for antidotes for certain poisons. And then finally, the disposition to decide on where the child needs to go, for example, to the ICU or to the ward, or the child can be safely discharged home. So resuscitation is important in certain poisons. So we always follow the ABCDE approach. So airway management is crucial in children present following poisoning, like poisoning with agents such as benzodiazepines or organophosphates or corrosives, which can cause mucosal burns or upper airway burns. And breathing can be compromised with agents, again, such as benzodiazepines or cholinergic agents such as organophosphates, or sometimes breathing can be compromised with aspiration of certain poisons such as liquid hydrocarbons, kerosene oil, and so on. And circulation can be compromised with agents such as calcium channel blockers, beta blockers, and tricyclic antidepressants, which all cause bradycardia and hypotension. And then some children can present with seizures. These seizures can be due to cardiac arrhythmias. These seizures can be due to hypoglycemia. So we need to find out why the child is having seizures. So we sometimes need to find the underlying cause and manage it rather than just managing a seizure with anti-epileptics. And blood sugar needs to be checked in all children with impaired consciousness or who are not conscious, and blood sugar needs to be corrected. And it's important to correct hyperthermia as well in the resuscitation stage, because it can be life-threatening. And this can occur in conditions such as serotonin syndrome or symptomimetic or anticholinergic toxidrome. And I will present what they are in the next slides. And sometimes antidotes are administered in the resuscitation table itself and the children recover. For example, naloxone for opiate poisoning. So if you administer naloxone, they need to be administered then and there. One good example is like we administer naloxone to children of whom the mothers were given pethidine during the normal labor. So children may have respiratory depression soon after birth. So if you want to give naloxone, then the naloxone has to be given them and there to reverse the respiratory depression. And then the decontamination with activated charcoal. So activated charcoal is like we use it, it's the most frequent agent that we use for decontamination purpose. So it effectively controls enteral and enterohepatic circulation of the poison. The usual dose is 1 gram per kilo, or the 10 times the dose of the poison. And some recommend that mixing with a flavor or ice cream or yogurt increase the compliance. Otherwise, we all know that's very difficult to administer activated charcoal to younger children. And it's very important that the airways are protected before we administer activated charcoal to drowsy children. Otherwise, it can lead to charcoal aspiration and chemical pneumonitis. And sometimes, so the drugs with significant enteroenteral and enterohepatic circulation, it's recommended that we administer multiple dose activated charcoal. And the indications include aspirin, barbiturates, phenobarbital, and theophylline. And activated charcoal is ineffective in heavy metal poisoning such as iron or lithium, and alcohol pesticide poisoning as well. And activated charcoal is generally contraindicated in the presence of bowel obstruction and GI hemorrhages and poisoning with liquid hydrocarbons and unprotected airway, where there is increased risk of aspiration. And gastric lavage, we don't frequently use as we used to do earlier. And it's currently only indicated in life-threatening ingestions that cannot be effectively removed by other means. For example, lithium and iron, which are not absorbed by activated charcoal. So your only early means of removing the poison would be gastric lavage. And it should be carried out only if there is adequate airway protection. So it's generally contraindicated in children who are drowsy or airway at compromise. And lavage is contraindicated in children presenting with corrosive substances because of the risk of chemical damage. And there are a few poison elimination techniques as well. So elimination differs from absorption because when a drug is, so if you consider the pharmacokinetics of the drugs, each poison has 4 phases. First one is the absorption, and the second phase is the metabolism, and the third phase is the elimination, and the fourth phase is the excretion. So this elimination phase, absorption, distribution, metabolism, and elimination. So this plays a role in the elimination stage. So elimination, so agents which help in elimination essentially helps excretion of agents that are metabolized as well as unmetabolized as well, right? So these methods include multiple dose activated charcoal and urine alkalization for substances which are excreted through urine, such as salicylates and phenobarbital, and whole bowel irrigation, and dialysis, and hemoperfusion and hemofiltration. Hemoperfusion differs from hemofiltration in that hemoperfusion uses a cartridge which contains an absorbing agent, usually activated charcoal, and as the fluid or as the plasma moves through the cartilage containing charcoal, effectively gets rid of the poison by adsorption, whereas hemofiltration is more or less similar to hemodialysis. So whole bowel irrigation is used in situations where the child had ingested modified release preparations or enteric coated formulations, in which case the poison is likely to stay within the gastrointestinal system for a while, so that these drugs may be staying in the GI tract as well as sometimes may be eliminated through the bile after initial enterohepatic circulation. So in that way, whole bowel irrigation helps in excretion of both the metabolized and unmetabolized poisons. And it also used in special occasions such as body packing. So body packing refers to individuals who ingest drugs or drug packets as a means of transferring these drugs from one place to the other, like for example, from one country to other country. So the only means of removing, because they have ingested large amounts of body packets. So one effective way would be to give whole bowel irrigation, and activated charcoal is generally contraindicated in these children, in these teenagers or people. And investigation. So these are the few investigations that we can consider doing based on a case-by-case basis. So if the child is unconscious or drowsy, always consider doing a blood sugar. And if the child has ingested, or we have a doubt about whether the child has ingested cardiotoxic agent, it's always good to do an ECG and then offer cardiac monitoring. And if the child is having vomiting, diarrhea, or if the child has ingested an agent such as sodium channel blocker or a calcium channel blocker or a cardiotoxic drug, it's always good to do electrolytes as well. And you can do blood gases in the unwell child. And if the child has ingested a radioactive substance such as iron containing oral contraceptive pills or lithium, then you can consider doing X-ray abdomen. And urine toxicology, we don't use in the emergency departments. Its use is limited, but it may help in places where you have medical legal concerns or safeguarding concerns to prove or disprove a child or a teenager has been given a poison. And then we can consider antidotes, a few antidotes to name, like glucagon for beta blockers, oxygen or hyperbaric oxygen for carbon monoxide, hydroxycobalamin for cyanide poisoning, and then digibind for digoxin or canary poisoning, then fameprazole or ethanol for ethynyl glycol poisoning, desferoxamine for iron poisoning, and so on. So as I told, like most of the children who are toddlers, their poisoning events may be trivial. So after a careful risk assessment, if they have minimal or no risk of having further complications, and if you can decide that no further treatment is required, then they can be safely discharged. And the symptomatic children, on a case-by-case basis, can be observed until they are out of danger. And safeguarding concerns, so poisoning events may have safeguarding concerns as well. So always consider and rule out if you have a doubt. And accidental injection is commonly a result of inappropriate or inadequate supervision. So it's always good to talk to them and then provide education, because recurrence is quite common, up to 30% in those who haven't been offered education about prevention. So one good thing we can do is we can refer to public health. For example, we can refer to the local public health midwife who can pay a subsequent home visit and then supervise or advise regarding the home safety to prevent further poisoning. And if the history is inconsistent or stories are not fitting with the developmental capabilities of the child, then they raise serious concerns about safeguarding, which has to be dealt according to the National Child Protection Safeguarding policies. And then poisoning and deliberate self-harm, which is seen in older children, teenagers. And this is quite common, although we don't see. Some children may present to hospital, some may not. So it's very important that if we come across a child with deliberate self-harm, irrespective of how trivial the dose is, they need to be referred to child psychiatry to arrange support, ongoing support and follow-up. So let's look at a few poisons. So I'll first talk about paracetamol poisoning. So the toxic dose is more than 200 milligrams per kilo over a 24-hour period, or if you consider repeated supra-therapeutic injections, 200 milligrams per kilo over 24-hour period, or 300 milligrams per kilo over 48-hour period. So in the box, the metabolism of paracetamol is shown there. Paracetamol is usually metabolized through the sulfation and glucuronidation. However, in overdose, cytochrome P450 pathway comes into play, resulting in formation of a metabolite called N-acetyl-P benzoquinoamine, which is toxic. And when you have enough glutathione stores, which means like when you are not malnourished, not an alcoholic, then you have sufficient glutathione stores, and then they reduce this toxic metabolite to non-toxic products. However, if the child is malnourished, or if you have taken a sufficiently large dose to saturate all the glutathione stores, then the accumulated NACU can result in serious liver toxicity as well as nephrotoxicity. So in overdose, it gets the absorption kinetics become quite prolonged, and you can see longer lasting toxic effects in higher toxic doses of paracetamol. So we can what are the markers of early injury? So liver function tests are not good enough to identify early injury. So the two recommended ones are the determination of the dose. For example, if the child presents with more than 200 milligrams per kg single overdose, then that's toxic. Or paracetamol levels if available. If the levels are above the treatment threshold, again, we consider it as potentially toxic. And the elevation of ALT may or may not be seen early. However, they are seen later. So they are useful as late markers of liver injury. And activity charcoal is recommended for paracetamol within 2 hours for immediate release preparations, or if the preparation is a modified release, then it can be administered effectively up to 4 hours following ingestion. And the antidote we administer is N-acetylcysteine. And the treatment endpoints are INR less than 2 and LT less than 50, and serum paracetamol level less than 10. So this is the nomogram, Rumark-Matthew nomogram we used in cases where the paracetamol levels are available. So I'll just briefly talk about these pathways. So this is about a poisoning event with a known time of ingestion following an acute single overdose. So what you can do is, if the child presents within the 4 hours, then you can administer activated charcoal and then do a level at 4 hours post ingestion if available. So if your dose is over 200 milligrams per kilogram, or if the levels available and if the levels are above treatment threshold, then it's recommended that you start acetylcysteine infusion. So the latest recommendation is that you use 2-bag regime rather than the conventional 3-bag regime, so which is administered as 100 milligrams per kilo 200 milligram per kilo over 4 hours and 100 milligram per kilo over 16 hours. So the total duration would be 20 hours. And towards the end of N-acetylcysteine infusion, you do liver function test, ALT. If it's less than 50, you can safely stop N-acetylcysteine infusion. And if the facility is available, you can do a paracetamol level as well. If it's less than 10, you can safely stop giving N-acetylcysteine. And this is for patients with repeated supratherapeutic paracetamol injections, for example, like erroneous administration by parents. Then the initial management would be the same. However, here you can't use the nomogram. So if your initial dose is over to 200 milligram, then you have to give a NAC. And then after 8 hours, you have to redo like liver function test plus, if available, a paracetamol level. And if there are available treatment threshold, for example, if the ALT is more than 50, then you need to continue the whole 20 hours N-acetylcysteine infusion. Or if the ALT levels are less than 50 after 8 hours, then you can safely stop N-acetylcysteine infusion. And then salicylate, it's another very important poison, which uncouples oxidative phosphorylation and inhibits Krebs cycle, and thereby increases lactic acid production. And this can result in multi-organ failure due to significant metabolic acidosis. And so we managed, because of this pharmacokinetics are deranged and the absorption is quite prolonged in significant poisoning, there is a place for gastric lavage as well as multiple dose activated charcoal in salicylate poisoning. And following absorption, the other methods of management include urine alkalization and hemodialysis. And yellow oleander, because we are running out of time, I'm trying to go a bit faster. So yellow oleander is another common poison seen in the rural areas, and its mechanism of action is the blockage of cardiac sodium potassium ATPase channels, resulting in hyperkalemia as well as various degrees of heart block and fatal cardiac arrhythmias, including ventricular tachycardias. So this is a child with cardiac poisoning and presenting with complete heart block. So these children need to be monitored for a longer period for up to 72 hours, and their electrolytes need to be monitored. And if available, you can do digoxin levels as well, because their absorption is quite erratic, and it might be quite difficult to predict the toxicity. So the treatments include multiple dose activated charcoal and the treatment of hyperkalemia. And then to counteract heart block, you can use agents such as atropine and cardiac pacing. And the more effective treatment is antidigoxin FAP. And then datura is a plant poison, which results in the anticholinergic toxidrome. So you manage that with standard lines of managing anticholinergic toxidrome, which includes activated charcoal and sedation to control agitation, and then cooling. And you can use antidotes in severe poisoning, and the antidote is IV physostigmine. And then castor oil plant, which is the most poisonous plant in our country, which can cause multi-organ failure. Its action is to inhibit protein synthesis. So it results in hemorrhagic gastroenteritis and multi-organ failure. So your management would be supportive and would be aimed at giving supportive care for multiple organ failure. And then kerosene oil poisoning, it's still the most common poison in our households. Most of the poisoning events may be trivial. However, it can lead to breathing difficulties, needing breathing support, and local decontamination. Activated charcoal is generally contraindicated. Steroids and antibiotics may be used, but there is no convincing evidence, so their use need to be decided based on a case-by-case basis. And ethylene glycol is another poison which is used in coolants and antifreeze used in cars. And children can present with drowsiness and CNS toxicity, and you can suspect with the clinical circumstances. Plus, if you do a blood gas, they will show metabolic acidosis with a very high unexplained anion gap. And activated charcoal is generally contraindicated here, and the antidote of choice is ethanol. But in severe poisoning, you need to consider hemodialysis. And then iron is another poison, like it comes as part of oral contraceptive pills and is one of the common tablets to be ingested by children. It can result in hemorrhagic gastroenteritis and multiple organ failure in severe poisoning with circulatory collapse. So these children might need intensive care from the beginning. As I told, activated charcoal is not effective in iron poisoning. You can try whole bowel irrigation or gastric lavage. And the antidote of choice is IV desferrexamine, which is indicated for children whose blood iron levels are over 3 milligrams per liter. And then tricyclic antidepressants is another significant poison, which cause blockage of sodium channels. And also in addition, they are having anticholinergic effects as well as cardiac blocking effects. So it results in various significant manifestations, resulting in life-threatening toxicity. So this ECG shows TCA poisoning. As you can see, it shows the widening of the QRS complexes. So this is a prognostic marker. So if the patient shows QRS prolongation, that indicates the risk of life-threatening cardiac toxicity as well as seizures. So management, because tricyclic antidepressants block sodium channels, your management is to give antidote, which is the sodium bicarbonate, to block, to compete with the sodium channel blocking effects of the tricyclic antidepressants, which you can do by giving IV sodium bicarbonate or promoting hyperventilation. And these children can have hypotension due to various reasons, due to alpha-adrenergic blockage and cardiac depression due to direct cardiac blocking properties. So if the inotropes are necessary, no adrenaline use is preferable to other inotropes, because the main way of causing hypertension is alpha-adrenergic blockade. And then button batteries are also important poisons seen typically in children. They are found in remote controls, thermometers, watches, calculators, and they can be lodged in upper airways and upper airway or esophagus, which can have deadly consequences. So this needs to be removed urgently. If the button batteries are lodged anywhere above the stomach, they need to be removed urgently. Whereas when you image the child, if the button battery has gone past the stomach, then you can manage to a conservative approach, and then can be just observing without any active intervention. And then there are a few less straightforward presentations. For example, a child or young person presenting with reduced conscious level with no known history of ingestion, or young patient or a younger child with altered or agitated behavior with no obvious cause, or young person who ingested recreational drugs. So these are like not very straightforward, but this can be due to poisoning or non-poisoning related event. So these events, clinical toxidromes help in narrowing down the differential causes in circumstances like this. But it's important to remember that we have to rule out other significant medical diagnoses such as septicemia, meningitis, colic crisis, brain hemorrhages, hypothermia, hypoxia when evaluating this group of children. So we'll see what these toxidromes are. So first is called opiate toxidrome. This occurs due to ingestion of agents such as heroin, which can be seen in neonate of a mother who is abusing heroin, or codeine, which is given as a pain relieving agent together with paracetamol. So when you overdose these agents, it can result in opiate toxidrome. And these children typically present with respiratory depression, CNS depression together with a pinpoint pupil. So if you know this triad, then you may try a dose of naloxone to reverse and see whether it's due to opioid toxidrome. And the other group is called somewhat similar, but it's not the same. It's called sedative toxidrome, occurs due to benzodiazepine poisoning. These children also have CNS depression and respiratory depression, but their pupils may be pinpoint or dilated, and also they can have hypotension and bradycardia. And for these children, the management would be supportive care, including ventilation. And then children who present with organophosphate, they present with a toxidrome known as cholinergic toxidrome. So if you have seen these children, they usually present with widespread urination, diaphoresis, diarrhea, bronchuria, vomiting, meiosis, salivation, and paralysis. So if the child is having this constellation of signs and symptoms, then you have to suspect this syndrome and then managed with agents such as atropine, palidoxime, ventilation, and so on. And then the other two are again somewhat similar, sympathomimetic and anticholinergic toxidrome. And what I put in red are the differentiating features of the two. And this group of children, they present quite agitated, usually teenagers after ingestion of either recreational drugs or sometimes they can overdose agents such as promethazine or tricyclics. So they present with anticholinergic. So both groups, they present with hypothermia, like fever, agitation, confusion, tachycardia, hypertension. So look somewhat similar. However, one group, due to sympathomimetic toxidrome, they will have increased sweating and increased bowel sounds, whereas in anticholinergic, they will have hypoactive bowel sounds and a dry red skin. So those two clinical features help differentiating this somewhat clinically similar toxidromes. But your management would be same. So you we have to calm them down using benzodiazepines, and then you can give them hydration. If they're hypothermic, then you have to manage with active cooling. And paracetamol has no effect in these types of children in managing hypothermia. So this diagram again shows in brief, in a illustrative way, how you can differentiate these clinical toxidromes. So what I want to highlight and the practice points we can learn out of this presentation are the risk assessment is crucial in initial evaluation of any intoxicated child, and that helps us prioritizing and triaging who needs emergent attention versus the children who do not need lengthy management. And then identification of toxidromes helps in arriving at the diagnosis early. And then other medical differential diagnoses also need exclusion in the unconscious child where you have a doubt about the poisoning. And safeguarding is very important. So safeguarding concern should always be raised in the presence of incompatible history. And children with deliberate self-harm, they do warrant referral to child psychiatry. Thank you very much.
Thank you, Dr. Kavinda, for the comprehensive lecture. Our next speaker is Dr. Kosala Karunaratne, consultant pediatrician at Lady Ridgeway Hospital for Children. He will speak to us on handling dengue during the COVID-19 pandemic. Over to you, sir. Kavinda, can you stop the screen sharing? Yeah. Thank you.
Hello, can you hear me?
Yes, we can hear.
Right, okay. Good morning. Thank you very much for this opportunity of talk about handling dengue during the COVID pandemic. So just to, again, regarding Eastern Province, I have a lot of ties with it. I started my career at Eastern Province. So it's quite close to my heart. And also to tell all of you that I had to walk into two epidemics at that time. Falciparum going with dengue. So here I am in front of you talking about handling dengue during the COVID pandemic. Okay, so just to go through the number of cases at LRH due to dengue coming in recently, compared to 2020, 2021, we are seeing an increase in cases of dengue coming in. There's a tenfold increase, as you can see. And also compared to the onset of the pandemic, that is COVID pandemic in 2019, December, 2020, January, the incidence has not gone up. But compared to 2020, 21, the number of cases are going up. And checking the national statistics as well. It's showing an increase in cases of dengue. So dengue during the pandemic is around the world is different. So in cases increase in many countries during the pandemic. In Brazil, 19% increase in cases of dengue seen. Thailand reported increased number of cases, as well as Ecuador reported one of the largest dengue outbreaks in its history. So mind you, these are the countries where COVID-19 is rampant. Okay, so dengue versus COVID. It's a little bit of a diagnostic challenge as well if they come in the febrile phase. So the symptoms, as you can see, fever, myalgia, skin rash, and fatigue are all very common in both conditions. And thrombocytopenia, lymphopenia, and increased liver enzymes as well. So basically, both may look similar in the febrile phase. Okay, so add to further confusion, there's a false positive serology. You see, if there is a case or a false positive dengue IgM in patients with COVID-19. So if you get a child with COVID-19, you can have cross-reacting antibodies to IgM, so which gives a false positive dengue antibody report. So first reported in Singapore in March 2020. In dengue endemic areas, this gives rise to diagnostic and public health concerns. But in countries where antigen is used as a rapid antigen test, not the serology, may not be a public health concern. But when you go to diagnose the late or the prolonged fevers with IgM, it may pose some degree of confusion. And if there's fever with positive dengue serology, screen for COVID as well. So again, what is dengue fever? So I won't go into dengue fever or any details about dengue fever, because I mean, all of us have seen and or virtually grown up with dengue, and for the last several decades. And also the febrile phase, critical phase, and the recovery phase is well known, and it will I won't go into details of how you differentiate these phases. Right. So this is the 2009 WHO classification of dengue. Again, everybody knows about it. The dengue with or without warning signs, and severe dengue. Severe dengue is severe plasma leakage, severe hemorrhage, and severe organ impairment. So this came in 2009, as opposed to the earlier classifications where they based the classification mainly on hemorrhages. So this gives a better understanding of the disease and also easier for us to manage this classification. Right, so let's move on to my talk today. The febrile phase of dengue. So in the febrile phase of dengue, the characteristic feature in dengue fever is the sudden rise of temperature. Sudden rise of temperature is so much so that an infant will throw febrile convulsion. So that's a bit of a unique feature in any viral illness, where you get a fever and a fit due to the virus itself. So another virus I can mention that gives rise to febrile convulsion is measles. Yeah, the virus causes sudden rise of core temperature. So that's not seen in many viruses. Even in corona, there is no sudden rise of core temperature. And also in corona, about 50% of children may not have fever. And if you see a child with corona with febrile convulsion, think of any underlying problem with the corona. So we saw 1 or 2 cases having a febrile convulsion, COVID positive, who had pneumococcal pneumonia. Right. So another feature about the fever in dengue that I should mention is the saddleback fever pattern, supposed to be classical in dengue. If you go through some of the histories in children with dengue, you find that they may have settling of fever somewhere around the third, fourth, fifth day, and another rise. This is not the effervescence. So if that is there, may help in your differential. And of course, none of these signs are not going to help you in differentiating dengue from the other viruses. So all these features may be present in dengue as well as most of the other viruses, including corona. So to confuse the issue, in July to September 2021, we saw an epidemic of MIS-C cases coming to LRH as well as around the country. So these are some of the statistics we have collected at LRH showing that there is, this is about 80 odd cases we analyzed, and they were the MIS-C cases were mostly found in children more than 7 years of age, and very rarely only happened in infancy. And also this slide shows you the venue of management of MIS-C cases. Most of them were managed in the ICU at the beginning, but the green column shows you the number that was handled in the wards. Mind you, at the latter part of the MIS-C cases coming in, most of the wards managed the MIS-C cases, including children on 1 inotrope. So if it was 1 inotrope not doing well, we sent to the ICU. Otherwise, most of our ward HDUs managed the MIS-C cases. So that trend was there, and we could analyze so many cases with that. Right. So again, what you see in this slide is a rash seen in dengue. So 2 of the rashes seen in dengue. What you see here in the main slide is a maculopapular rash, as well as in a white skin, how you see it. It's a truncal maculopapular rash you see in dengue, spreading to the face, which is contrary to some viruses like measles, where it starts from the face, measles, roseola, where it starts from the face and spreads to the trunk. But here is a rash, it starts in the trunk and spreads to the face. And the other rash that you can see is the purpuric rash that's described in dengue. Mind you, this rash we don't see often. When you see it, most of the observational studies are showing that the purpuric rash is more common in dengue fever rather than dengue hemorrhagic. And of course, in dengue hemorrhagic cause, you can get the purpuric rash, where it is seen usually in the recovery phase. So these are 2 of the rashes you see in dengue that cause a little bit of confusion during this epidemic. Here is again a rash that we saw during the July-October epidemic of MIS-C, where you can see a typical maculopapular truncal rash in this child. But what is different is, if you notice, is the lips and the eyes are red, and of course the eyes are a bit swollen as well. So this is the KD variant of MIS-C, where it is not very common for you to see swollen eyelids in dengue, but you could see red eyes, sometimes red lips in dengue, especially when dengue is co-infected with adenovirus. Anyway, so this posed a little bit of problem when they were pouring in, and at that time cases of dengue were also rising. So this is another child who came with a MIS-C showing the classical strawberry tongue. And if you see a red dye with fever, again, dengue, you could get red dyes, but in MIS-C, what you see is a Kawasaki type of redness where there's limbal sparing. Of course, this is the typical, textbook rash of a recovering dengue. So islands of white in a sea of red, but this you see in recovery. But if you see this in the febrile phase, it will be the sea of red, or just like a scarlet uniform rash or redness. So he is a child with Missy who came with the toxic shock-like presentation, who had almost like the scarlet uniform rash. You can see that very well. And this child caused a little bit of confusion. Was it a scarlet fever? Was it dengue? Toxic shock? So we have to treat for all and then come to a diagnosis with investigations. Okay, so the case definition of Missy is consisting of fever of 3 days, more than 3 days, and evidence of 2 or more organ involvement. So usually what we saw is mucocutaneous skin involvement with gastrointestinal symptoms. So that was the commonest presentation we had, and most of them had coronary involvement as well. And some of them went into severe Missy indicated by cardiogenic shock. And rarely we saw some of the cases coming in Missy having respiratory symptoms with some little bit of skin and mucous membranes, respiratory involvement, lung involvement. So that was a bit of a variation as well. So these were some of the cases that caused confusion, but the lot of light came in with the investigations with our tier 1 and tier 2 investigations gave us a lot of indications that it was Missy rather than other viruses or other exanthems. So, but in Missy, most of the RT-PCR and RAT was negative and antibodies were positive. But at that time, since there were so many cases going around, antibody titers were useful. Titers of more than 10 was used as an indicator that it was COVID infection recent rather than just it being positive. Right. So I just go through a few cases that we saw across it that time that will be useful for you to anticipate certain cases, similar cases in the future. So this is a 7-year-old child who presented to LRH with a 5-day history of high fever. On examination, child had a generalized maculopapular rash. His eyes were found to be red. Full blood count was 4,300, neutrophils 52, and lymphocytes were 41%, platelet 83,000, CRP 240. Ultrasound scan showed thin rim of fluid in the hepatorenal pouch. Dengue antigen was negative. Now, this is the type of scenario we saw in several children, where children were coming, okay, almost like dengue, but the giveaways were some of the inflammatory markers, where the tier 1 and 2 investigations were helpful. Now here the CRP was 240, but now about the thin rim of fluid in the hepatorenal pouch, we saw very commonly in the Missy cases due to serositis. So this is not leaking dengue. So right. So thin rim of fluid in hepatorenal pouch. So here are the tier 2, tier 1 and tier 2 workup we made in our guidelines. So that was useful because inflammatory markers were very high in Missy compared to dengue, where CRP was very high, ESR was high, but in some cases they were not that very high. So then you had to move on to your tier 2 investigations, where the SARS-CoV-2 serology took some time to come. So at that point, I mean, investigations like D-dimers were very helpful because they were found to be quite high in Missy, and also the cardiac investigations. But mind you, ferritin can be high in both conditions. Ferritin can be high more in dengue because in severe dengue it can go up to even 1,500, 2,000. Then this forgotten test was very useful for us as well. So don't forget about this test if you are in doubt. Febrile phase. So a child coming in the febrile phase with dengue with warning signs, it was again a diagnostic challenge because most of the Missy children came with a history of about 3 to 5 days fever with severe abdominal pains. And in fact, some of them ended up in the surgeon's tables as well and requiring appendectomies to see that it was Missy. So it was not, I mean, it was a diagnostic dilemma at that time, with who came with severe abdominal pains, persistent vomiting, change in sensorium, and mucosal bleeding had epidemiologically favored more dengue rather than MIS-C or severe COVID infections. Thrombocytopenia, again, not helpful. Increasing hematocrit, if it was there, it was helpful. Critical phase. So critical phase of dengue can be either non-severe disease or severe disease according to the 2009 classification. In severe disease, dengue shock syndrome, severe hemorrhages, severe organ injury. Dengue shock syndrome can be either reversible shock or profound or irreversible shock. Severe hemorrhages need not be only seen in dengue hemorrhagic fever if the patient was on NSAIDs. The severe hemorrhages could even occur in DF as well. And again, severe organ involvement. Now there is this expanded dengue syndrome where you get severe organ involvement even without patient being in critical phase, like encephalopathy. And during this MIS-C epidemic, we saw some of these extended dengue syndrome type of cases, which I'm going to discuss. So dengue shock syndrome was a MIS-C shock, was a dilemma in the EU as well. So because MIS-C shock is more cardiogenic and vasopressor, so more of a warm shock, where features of cardiogenic shock was seen, like third heart sound and pulmonary edema was more in MIS-C shock. And in dengue, the key feature is narrowing of pulse pressure. So if you get narrow pulse pressure, it's likely to be dengue shock rather than MIS-C shock. But most of the children we saw during this epidemic was basically having hypotensive shock. So when it came to hypotensive shock, the narrowing of pulse pressure was not appreciated that much. So some of our tier 2 investigations and point of care ultrasound scanning was useful for us. So tier 2 investigations took a little bit of time. So I mean, we found that focus, point of care ultrasound scan being useful. Now here is your IBC collapsibility, which we used in some of these cases and found it to be very useful. And also the ultrasound scan can be a crude way of assessing your ejection fraction as well, but I wouldn't recommend just to go by that alone. But in an emergency, now say a child coming with hypotension and features of both, you have to take a clinical decision fast, because now here is a situation. Okay, hypotensive shock was a profound hypotensive shock of dengue was a MIS-C. So are we to give more fluid boluses? So if it is a profound shock, we have to give at least 2 boluses or 20 ml per kg fast, followed by dextran. Or are we to give 20 ml per kg bolus? Anyway, we were giving 20 ml per kg boluses in hypotensive shock in MIS-C as well, because they were hypoplegic and vasoplegic. So until we got the investigations, we anyway gave the quick bolus. But giving a dextran, I don't know whether it's a good idea in MIS-C. So you have to come to a decision fast. And of course, if it is MIS-C, you have quickly start on methylprednisolone and immunoglobulins. So some of these investigations were useful. Now, again, another case I'm going to illustrate now that is, I think, is very important for my presentation. So what I was talking to you about confusion of MIS-C with dengue. Now, here is a child, 7-year-old girl, transferred to LRH from Caravanal, July 2021. This child presented to Caravanal in shock, and the child had dengue antigen positive and treated according to national guidelines at Caravanal Hospital by the able pediatrician there with good success in managing the leaking part and the shock. Even after recovering from shock and end of leaking, patient had been found to be very ill with high continuous spikes of fever. So with that setting, the child was discussed and transferred to my unit. And the patient continued to have very high spikes of temperature no improvement in platelets, but that you expect in the recovery phase. Ferritin was found to be 2,600, D-dimer 6,200. And mind you, doing the echo showed the coronary involvement as well. So going through this case, what you see is a child clearly in dengue who had shock, severe dengue, having MIS-C. So this clearly a mixed infection. So a child having a MIS-C infection, having very severe disease. Now this child needed immunoglobulins and methylprednisolone as well as inotropes. We gave one inotrope in the ward, then child recovered fortunately. Yeah, child was not shifted to the ICU, did quite well after our treatment. So, okay. So I'm coming to the last part of my presentation, dengue and COVID-19 co-infections. So this is probably something we should look out for and worry about. Co-infections associated with no severity, associated with complications. Like it's associated with complications like septic shock, ARDS, and MODS. Now here they have found a lot of adults with dengue having co-infections going into severe ARDS of COVID. And even in children, children having comorbidities may have severe corona if they have co-infections. And there's a high risk of death. So I just want to give attention to all of you regarding a case series done in Bangladesh very recently. Severe dengue with MIS-C, a co-infection case series. This was published in November 2021. Bangladesh currently facing a double burden of severe dengue and COVID. All children presented with shock and plasma leakage. Mucocutaneous and gastrointestinal involvement was very common in these children. And echo had shown coronary involvement in all these children. So this was an example of co-infection causing severe disease. And in fact, this is almost identical to the Caravanella case we had. So, and we saw, and mind you, we saw two similar cases as well during the MIS-C epidemic. And I'm thinking of publishing these cases. And not only that, there are other forms of severe disease due to dengue we are now encountering. Again, illustration of two of the cases we saw in the last 2-3 weeks. Now, here is a child who is 6 years old, previously healthy boy, presenting on 12th January 2022 with a history of fever, vomiting, abdominal pain, right upper arterial pain for 3 days. The child had high fever and dengue NSN1 was positive on day 2 of fever. The child was monitored with the febrile phase monitoring, daily blood counts and ward leaking scans. So during the ward stay, detected to have peripolycystic fluid and fluid in the hepatorenal pouch. Managed as DHF with critical phase monitoring and appropriate fluid management. So critical phase had gone on for 48 hours and managed with maintenance of 5% and 100% of fluid had been used. Even after completing the critical phase, child was having persistently high fever, spikes with severe abdominal pain. No contact history of COVID-19. Now, this is just recently. So, for 2-3 weeks back, this child was just discharged from the ward. And on examination, the child was very ill-looking with red lips, red eyes. There was no limbal sparing. And the child had tachycardia. There was bilateral vesicular breathing and reduced air entry and signs suggestive of a right-sided effusion. This child had leaked, so the signs of effusion. Abdomen, liver was palpable, but CNA was normal. Now here, what you see is a child with dengue was treated due to leaking, and there was no shock, so it was not a severe disease. Having persistent high temperature, having these investigations. What you can see is the child's WBCs were recovering slowly, but the ESR seems to be quite low compared to the CRP, which has dropped a bit as well. Your functions were still going up, and other tests were normal, but LDH was quite high. But what is striking is your ferritin, which is in is 12,000. So what you can see here, with those findings, we thought this child had HLH, and this is the fever chart the child had after leaking. No temperature didn't drop. With these investigations, we decided the child had HLH. Although the 2004 criteria didn't agree with the HLH, we went ahead with methylprednisolone because the child was quite ill. And bone marrow was done after the methylprednisolone. We couldn't wait. And bone marrow showed hemophagocytosis. What you can see is hemophagocytosis macrophage. Okay, this is another child who presented just 1 week before. About 1 or 2 weeks before, this child was in our ward for a long time. We were treated 11-year-old previously well child who presented with fever, cough, and managed as a lung abscess with IV antibiotics, on prolonged IV antibiotics. And fever settled after 5 days of antibiotics, but the child was on a long course of antibiotics. While in ward, the child presented with high spikes of temperature on the 16th day of antibiotics, and was found to be positive for NS1 antigen when the fever was going on, and we noticed the platelets were dropping. So because of the lung abscess, the platelets were around 600,000 to start with, but it was gradually dropping very fast. So you were wondering whether this child was having something. It was dengue. So but then it showed that NS1 was positive. But the child did not have leaking at all. Child was continuing to have very high fever. Then the rest of the investigations were done, and the ferritin came as 31,672. Right. So again, another case of HLH. So what is happening? So are we seeing more HLH cases? In the first case that I mentioned, the child's antibodies, COVID antibodies were negative. But this child, unfortunately, we didn't think of a co-infection, so we didn't do a serology as such. But now here what you see is the very high temperature responding to methylprednisolone. Okay, so secondary HLH, well known in dengue. So in dengue, the HLH is well described in children series as well as in adults. So here are the criteria that are used for HLH, where 1 or 2 can be used. One is molecular diagnosis, because with HLH, which we can't do in Sri Lanka. So we go by clinical criteria, where 5 out of 8 criteria should be fulfilled. But both these children, none of these, I mean, the first child only met 3 criteria before the bone marrow. With the bone marrow, with the hemophagocytosis, it was only 4 criteria. So you can't wait. So go for HLH score. So that is well validated in HLH and very useful in infections like dengue, where a probability of the disease is given by the H score. And you can see in the H score, the ferritin is given a very high score. It is given, if it is over 6,000, is given as 50. And 2,000 to 6,035. So it's the single most important investigation in this infection. So I'm not telling you not to do a bone marrow. Do a bone marrow, but in children having severe thrombocytopenia and dengue, sometimes the hematologist is not going to be very happy to do a bone marrow. So use this score. So HLH diagnosis can be done by 5 out of 8 for 2004 criteria, or H-score probability of 70% or more. So what you can see here is how H-score can be increased after ferritin. So we had a score of 200 in our case, the first case I described. So 200 comes to nearly 80 to 88% probable to be HLH rather than any other disease. So H-score without ferritin is 25 to 40%, with ferritin 200, and with bone marrow almost 100%. So hyperferritinemia is associated with secondary HLH and dengue as well, and severe COVID infections. So in dengue, I mentioned to you that up to about 1,500 is a cutoff for dengue in ferritin. because some children I have seen going up to 2,500, maybe even 3,000. But if you see a count more than, I mean, ferritin of more than 10,000, think of HLH. Even in COVID, severe COVID pneumonias, you can have ferritin going up, but never over 10,000. So dengue associated HLH is more commonly seen in severe dengue and associated with serotype 2. So both the cases I presented to you are not severe cases. So the first case was just a leaker. Second case was an abscess who didn't leak at all. And the serotype 3 is the one that is circulating around these days. So what are we seeing? Are we seeing a mixed infection again? So of course there are concurrent COVID-19 and dengue HLH case reports. So beware, we might see more cases like this in the future. So I just want to bring to your attention of a case series we did in 2018. That was the Ruhuna epidemic of respiratory SARS type of presentation due to adenoviruses. So there are lots of SARS type of presentation due to adenovirus with superinfected H1N1. That was what was going on in 2018, and we analyzed a case series where this dual infection was very commonly associated with HLH. Again, H2O was very useful. Multiple antibiotics and antivirals didn't help these children, but steroids did, and with dramatic results. So if we are having dual epidemics going around, think about these conditions. Okay, I'm just going to end my presentations. In summary, dengue incidence is what on the rise during the pandemic. So it is seen in around the world and the region where dengue is endemic, Southeast Asia and South Asia. And also I heard from the EPID department, now the dengue is going to be going up during this year. So more severe dengue disease types are recognized with my cases that I have presented today. It may be a result of co-infections. So in the future, we are going to have both viruses which are going to be endemic. So then endemic dengue is already there in Sri Lanka. So with the Omicron coming in, now it looks as if Corona will become endemic as well. So beware of dual infections and the complications. Thank you.
Thank you very much, sir, for the very interesting presentation. We will now take a short break for about 5 to 10 minutes before we continue with the rest of the session. Thank you.
I think my recording is
Okay, welcome back. Our next speaker is Dr. Sujit Gunaratne, consultant neonatologist, teaching hospital, Batticaloa. He will talk to us on therapeutic cooling in newborns. Over to you, Dr. Sujit. Sujit, can you unmute, please?
Oh, can you hear?
Yeah, we can hear you now. Can you start from the
Good afternoon to all. So first of all, I would like to thank for College of Pediatricians Sri Lanka to giving this opportunity to me to discuss regarding neonatology topic in the regional sessions of College of Pediatricians in Eastern Province. So today my duty is to discuss regarding therapeutic hypothermia in newborn. So during this my lecture, I'm going to give a little bit introduction regarding HIE, and then the pathophysiology behind the brain damage during hypoxic ischemic encephalopathy. Then how to assess the clinically that grading of HIE. Then why we need to do therapeutic hypothermia in baby with the HIE, and basic step of therapeutic hypothermia and supportive care and monitoring during cooling. Those are the topics I'm going to address during this lecture. So what is the hypoxic ischemic encephalopathy? It is a term used to describe the clinical and neuropathological findings of an encephalopathy that occur in neonate who has significant episode of intrapartum asphyxia. Most important word is intrapartum asphyxia. There are several causes for the neonatal encephalopathy. From that, today we are going to talk about the hypoxic ischemic encephalopathy. So incidence is not that very low. It is 1.5 cases per 1,000 live birth in UK, but in developed countries, that is low and middle income countries, it is high as 10 to 20 per 1,000 live birth. That means incidence is very high. So cause permanent damage to the CNS tissue leading to death or cerebral palsy or permanent neurological disability. So about 20 to 30% who that from that babies who got HIE died, and 33 to 50% have permanent neurological disability. So if baby has evidence of severe hypoxia, anyway that indicating less than 6.7 and base deficit excess more than 25, will have very poor outcome. So then etiology. So we can divide etiology into the maternal factors and neuroplacental factors and fetal factors. So what are the maternal factors? So hypoventilation from anesthesia, that mother has undergone that general anesthesia, is high risk of having fetal hypoxia. Then low blood pressure during spinal anesthesia. Then mother with synovial heart disease. Then acute blood loss, APH, and postpartum hemorrhage. Then compression of venous cava and aorta by gravid uterus. The neuroplacental causes the premature separation of placenta, that means placental abruption. Then placental insufficiency from forced maturity. Sometimes that baby delivered forced term can have that means hypoxic event. Then knotting of cord and cord round around the nose. So then there won't be a blood supply to the fetus. Anyway, fetus will have hypoxia. Then uterine rupture and uterine hyperstimulation due to excessive oxytocin. This is the preventable things that we can minimize having fetal hypoxia, that is hyperstimulation. So proper monitoring should be done during neighborhood to detect this cause because it is preventable. So then fetal causes severe spinal heart disease, and then cardiac arrhythmia, then severe anemia that can be due to severe fetal hemolysis, that means intrauterine hemolysis due to hemolytic disease of newborn, RH incompatibility, and fetal maternal hemorrhage. Then other causes are stroke due to that massive blood loss, intracranial hemorrhage, or axillary hemorrhage, or sepsis. Then next few slides I will discuss regarding the pathophysiology of brain injury during hypoxic ischemic encephalopathy. So there are two main phases, so primary energy failure and secondary energy failure. So what will happen? In primary energy failure, with this hypoxic ischemia, what will happen? There will be an anaerobic glycolysis, so that ATP depletion, so it will increase glutamate excitatory neurotransmitters, will increase that NMDA receptors, will change that intracellular calcium and sodium levels, which activate lipase and activate nitric oxide synthase. So will lead to formation of free radicals. So oxygen with combined with oxygen and then make free radicals. So remember here that free radical is the main cause of brain damage in acute phase, which lead to necrosis, cell necrosis in primary energy failure. Then there is that mean later that phase called latent phase. The brain will act, regain their, that will recover their metabolic function. This phase is known as the latent phase. So, but in this phase also, this mechanism is continuing. 6 hours phase from birth to 6 hours. Usually, primary energy failure for the first few minutes. Then from that up to 6 hours, there's a latent phase. So after that, secondary energy failure. What happens in secondary energy failure? Confirmation of exercise toxic oxidative cascade. Due to that mean high activation of excited neurotransmitters. Then activation, it will activate microglia. Inflammatory response will generate activation of the caspase protein. Then it will lead to intracellular, that means cellular death and apoptosis. So here you can see there are a nice 6 hours period. This transient period from this acute necrotic cell death to apoptotic cell death. So if we can do something in this period to this baby with the HIV, then we can have good outcome. So that if we are doing some intervention to prevent further brain damage, we have to start during this golden 6 hours in baby with the HIV. So then we should be able to rate clinical. We should be able to clinically assess the severity of the hypoxic ischemic encephalopathy. So for that, we use modified Sarnet rating. So you can see here that we can divide HIA into mild, moderate, and severe. So there are several components I'm not going to discuss because we have to chart the therapeutic hypothermia part as well. So then therapeutic hypothermia. So therapeutic hypothermia involves reducing baby's core temperature 33 to 34 degrees of Celsius for 72 hours within 6 hours of birth, followed by gradual rewarming at a rate of 0.5 Celsius degree per hour till core temperature reach to 36.5 to 37. So there are two methods. I selected head cooling and total body cooling. I will discuss those things in later. So then, how it helps to that with hypothermia, how it helps to prevent the brain damage in HIV. So as you know that we mainly apoptotic cell death. So by doing hypothermia, so it will decrease the energy depletion and reducing metabolic demand. Maybe that you know when there is low temperature, it will reduce the metabolic rate and then energy demand. And other important thing by doing that, it inhibits the release of excitatory neurotransmitters like glutamate. Then inhibit inflammation are the most important thing, blocking downstream cascade of intracellular event leading to apoptosis. So those are the ways the therapeutic hypothermia helps to prevent brain damage in hypoxic ischemic encephalopathy. So why we should do the therapeutic hypothermia? Before that 2005, there was no that mean accepted mode of treatment for the hypoxic ischemic encephalopathy. So that they have done COVID trial and published on 2004. After that, they have noted the therapeutic hypothermia has marked effect on brain damage. So the 2013 the Cochrane database, there were 11 studies has been done to compare that in effect of therapeutic hypothermia. They have found that primary outcome measures of less death and better neurodevelopmental outcome for survivors. That means the baby who survived from the HIV after cooling has better the neurological outcome and survival rate also high in later phase. But initial phase, that both, even though that baby underwent cooling or that baby not underwent cooling, there is no difference between death rate. But baby who survive after cooling, initial phase, there's a marked difference between that neurological outcome and survival during the early stage of life, baby who was underwent therapeutic cooling. Another thing that they have assessed the baby's development disability at 18 months of age. So there is marked improvement in baby, that means improvement in the babies who underwent therapeutic cooling. Their neurological assessment is, the neurological function is very good. Then another trial, that means initially the National Institute of Child Health and Human Development study was done at 2 ways. So after 6 to 7 years, they assess the baby's neurological outcome with the IQ and motor skill and fine motor skill. So they have found there is marked improvement. That means most of the time IQ more than 70. Baby who has underwent therapeutic cooling during initial stage. So that's why we should start therapeutic cooling. Baby who has moderate to severe hypoxic ischemic encephalopathy, it will give that better long-term outcome for the baby. So I think you have seen that mothers with baby who has a CP due to a child. So if we can start cooling in initial stage, so it will give the proper long-term outcome for that family. So this is the starting therapeutic cooling at early stage. Actually, is that mean we are helping to prevent that burden to family as well as the economical. We are the third world country. So to maintain that type of baby, we need to expend a lot of money. So if we can start with therapeutic cooling at the initial stage, we can minimize that cost as well. Okay, so that's why we have to start therapeutic hyperthermia. So then, who are the babies need to do therapeutic cooling? These criteria taken from the TOBI trial. So infant babies born more than 36 weeks of gestation with the one of following, that with for less than 5 and 10 minutes continues to need for resuscitation, including endotracheal or mass ventilation at 10 minutes after birth. Acidosis within 60 minutes of birth, pH less than 7. That means blood gas done within first hour. It could be that capillary, venous, or arterial. Any blood gas, if pH is less than 7, it's that mean indicate there is a fetal hypoxia. Then base deficit more than 16 millimole per liter, umbilical cord, any blood gas done within 60 minutes. So these criteria A indicate that baby has underwent marked hypoxia, significant hypoxia inside the uterus. If baby have one of these criteria, then we should look for this CNS criteria B. So moderate to severe encephalopathy consisting of altered state of consciousness and at least one of the following: hypotonia or hypertonia. Then abnormal reflexes including the ocular motor or pupillary abnormalities and absent or weak sub and clinical seizures for this AEG, amplitude integrated EEG recording. It has some abnormal seizure activity or that moderate abnormal background activity. It is also indication for the therapeutic cooling. So in next 2 slides, I will explain a little bit regarding amplitude integrated EEG, because for the completeness you should not know these things that mean for the depth. So amplitude integrated electroencephalography is a continuous monitoring of brain function that is used increasingly in neonatal intensive care unit. And this method based on the filtered and compressed EEG that enable evaluation of long-term changes and trending electrical background activity. So there are 2 ways of analyzing the voltage classification and pattern classification, but we used to use that our DNA we use that means voltage classification. So normal voltage classification, normal EEG function means that lower margin is more than 5 microvolt and upper margin is more than 10 microvolt. The moderate abnormality, low margin less than 5 microvolt, and upper margin more than 10 microvolt, and severe, lower margin less than 10 and upper margin less, so low margin less than 5 and upper margin less than 10. So then therapeutic cooling, I told that previously there are two methods, the total body cooling and isolated head cooling. So in total body cooling, the target rectal temperature, we insert rectal probe before starting cooling, and then we maintain temperature between 33 to 34, the 33.5 for 72 hours. And head cooling, we cool head up to 34.5 centigrade. So we will maintain it for 72 hours. So comparison between head cooling and total body cooling. So initially they have mentioned that there are limited number of studies, but initially they mentioned there is no difference between selective head cooling and total body cooling. But later they have done studies with a good sample size. They found the MRI findings in late and neuro disabilities less in baby who was underwent total body cooling, because the reason they have given during therapeutic total body cooling, the whole brain will get cooled the same degree of Celsius. But in selective head cooling, the brain won't cool evenly. So there can be more brain, comparatively more damage in selective head cooling. So nowadays we are using for body cooling. So the therapeutic cooling, we use this technical, this machine. This is the plan. This is plan program. We should give the values to the machine, and we should cover the baby with a blanket, and then we should start the switch. Then machine will run continuously. There are the manual mode as well. Then it will cool for 72 hours. Then it will start rewarming phase. So rewarming phase, that we should say the maximum degree of Celsius should be 0.5 Celsius per hour. So the supportive wise, we should have proper IV access to UVC, and we have to do the cranial ultrasound scan, bedside cranial ultrasound scan, because if baby is having major brain malformation, there is no point of cooling. So we have to have cranial ultrasound scan. If available, we can start AEG monitoring as well. Then ventilation in a baby with therapeutic cooling. Almost all infant, actually, if you go to that criteria, you can see the most of the babies need respiratory support at 10 minutes. So most of them are ventilated, but cooling does not affect respiration. If baby's lungs are okay, his brain, the respiratory center is functioning good, then later the respiration will recover. So there is no point that telling we have to continue ventilation till the end of the cooling. So if baby is clinically okay, baby is having spontaneous respiration, we can take baby from ventilator and continue the cooling. But most of the time, the persistent pulmonary hypertension, meconium aspiration may be present with the hypoxic ischemic encephalopathy. So that occasion, we might need that nitric oxide therapy and high frequency oscillatory ventilation like advanced ventilator support for these babies. Then cardiovascular support. So usually due to the therapeutic hypothermia, these babies has low heart rate, because drop of each degree of Celsius usually reduce 10 to 15 beat per minute of heart rate. So usually their heart rate between 80 to 100. So this baby is having 120, 130 heart rate. Baby who is on therapeutic cooling. So then we have to suspect some conversion or other that will be the baby is having tachycardia. Then most of the in a rewarming case, baby can have hypotension. So we should have proper monitoring. And if baby is developed, baby because HI, hypoxic encephalopathy affect that it is multi-organ disease, can affect heart, liver, and kidney. so that if they develop hypotension, so we should start unprognosticated. So then seizures, if baby has seizures more than 3 minutes or 3 seizures per hour or subclinical EEG abnormalities, we have to start anticonvulsant therapy according to the neonatal guideline of management of convulsion. So then fluid management, it is also a very important part of HIE management. Usually term baby birth rate more than with a good birth rate more than 100, we starting 60 ml per kg. But here, because as I mentioned earlier, that it is a multisystemic involvement is there, so we restrict the fluid. 40 usually starting from 40 ml per kg per day. If baby is having polyuric acute kidney injury, we can reduce it up to even 30 ml per kg per day. But we should monitor the baby's renal function and urine output. Then we have to catheterize and 6-hourly fluid balance should be done. Then investigation at the admission, we have to do the blood glucose. It is very important. I told that we have to reduce fluid intake. Then if we start at 10% glucose as a supplement, I mean nutrition thing, so there won't be adequate GIR to make a good metabolic function. Then baby can have hypoglycemia. So that we should increase the glucose concentration to adequate GIR to maintain the normoglycemia. So CBS monitoring is very important. Then we have to do the septic screening because one of the leading cause for HIE is a intrauterine infection. So then coagulation we have to do, and blood gas, serum electrolyte including calcium, magnesium, and after 6 hours we can do troponin I available, so that we can have some idea about the cardiac function, that will affect the level of involvement of the heart. Then daily we have to pull that count, protein profile, renal function test, and liver function test. But in our settings, these are the ways for the UK. We will go with the clinical picture of the baby, and we will decide when to treat. Then the coagulation, most of the time they have coagulation abnormalities. So with the report, we will manage them according to using the blood product. Then GIT regarding enteral feeding. So sometimes we have some problem. We are thinking that metabolic rate is not good. So we do not start feeding while baby is in cooling. But there is no point like that. We can start feeding while baby is in cooling. If baby's other system, it depends on the baby's multi-system involvement. So if baby is not having feeders of neck and abdomen is okay, no aspiration, we can start feeding. So starting enteral feeding, early start enteral feeding has DBA, not a formula. We have to start express decimally has good outcome in the baby. Then deworming, so cooling we concluded after 72 hours. Then the rectal temperature should be allowed to rise by more than 0.5 hour up to 37, and rewarming can be carried out by adjusting thermo set point and the cooling machine, as I mentioned earlier. And we have to carefully monitor the temperature for 22 hours because the rebound hypothermia can occur during these first 24 hours. Other important thing, as I mentioned earlier, that due to vasodilatation there can be a hypotension. Another thing, that metabolic rate will go up with this increased temperature, so that baby can have conversion. So we should keep our eye on baby to detect the conversion during this rewarming phase as well. Then adverse effect of cooling, as I mentioned, that bradycardia, prolonged QT interval, ventricular arrhythmias, hypotension, reduced cardiac output, and reduction of respiratory device, reduction of surfactant production, and increased pulmonary vascular resistance, and metabolic wise hypokalemia, hypomagnesemia, and hypophosphatemia, and coagulopathy, GIT, gastric empty. And drug wise, there can be the prolonged action of the drug. So sometimes if we start sedation, then we have the effect of the drug for long period due to hypothermia. Then diagnosis, we have to do the cranial ultrasound scan and EEG, and then CT pain has less information. So best investigation to detect the level of insult to brain is MRI brain. We have done after 4 days, in 5 to 14 days, that we can have good information regarding brain damage. Then this is very important slide. So most of the time that in Sri Lanka we have limited number of polling centers. One, but all provinces has one polling center. So we can transfer, if we have a baby, we can transfer baby within 6 hours. So luckily, particularly also we have therapeutic polling machine here. So if baby born outside the polling center, what we have to do? So our aim is maintain body temperature between 33 to 34. Then we can switch off up. So before that, so I forgot to tell, before starting therapeutic polling, we have to optimize the baby's airway and circulation. After stabilization, we have to start hypothermia, therapeutic hypothermia. Here also after stabilization of the baby, so we can wait, switch off the warmer, then wait for 30 minutes. Then if temperature above 34, we can remove the clothes. And if 34, we do not need to do anything. If baby has below temperature below 33, then we can add a blanket. Likewise, we can. The main aim is to maintain body temperature between 33 to 34 and contact polling center immediately. Transfer baby to polling center within 6 hours. That's the most important thing. So prognosis range from complete recovery to death. I mentioned that incident rates previously, and prognosis depend on the severity of insult and treatment. And poor prognostic factors are initial blood gas pH stands at 6.7 and less than 3 at 5 minutes. High base deficit and dicerebral posture and severe basal thalamic lesions in MRI. Then persistent severe HI at 72 hours and difficult to establish feeding within 1 week. And then the early identification of neurodevelopmental problems and follow-up is needed for these babies. Initially 6 to 8 week follow-up and 3 to 6 month follow-up later. And we have to use good neurological assessment tool like daily scale and other important things. These babies should be managed by the multidisciplinary team including pediatrician, ENT, occupational therapist, physiotherapist, educational therapists, and orthopedic and rheumatologist. So then what about the new emerging things regarding therapeutic cooling? So usually the therapeutic hypothermia indicated mild to the moderate to severe HI. Now they are doing that cooling in mild encephalopathy trial, homemade trial. So they have noted that baby who has mild encephalopathy who do not underwent cooling has 50% affected babies have mild encephalopathy. They have very weak even MRI, and 1/3 has some long-term neurological outcome. So now they are doing research studies regarding therapeutic cooling, whether there is indication for therapeutic cooling for these baby. Then they will publish their results in this year. Another thing, another study is going on. So baby who is the marginal preterm, we are calling baby who is more than 36 weeks. So 34, 35, 33, 32 to 35 weeks they are doing studies. What is the effect on therapeutic cooling in those type of babies? So take home message. So as I mentioned previously, HI is major issue in country like us. So with having severe neurological disabilities, so as we are having therapeutic hypothermia, that we cooling centers in our country from 2019, so it's important to transfer the early detection and transfer this baby to cooling centers and start therapeutic cooling. And other thing is proper follow-up with the good developmental care is very important to have good neurological outcome in this baby. Okay, thank you.
Thank you, Dr. Sujit, for the informative presentation. Our next speaker is Dr. Vijay Thirukumar, Senior Lecturer in Pediatrics at Faculty of Healthcare Sciences, Eastern University of Sri Lanka. She will present to us on honor-based violence, awareness, and recognition. Over to you, Dr. Vijay.
Thanks, Roshan. Good afternoon to you all. Anyway, once again, I want to thank our College of Pediatricians to arrange this program. This is an interesting topic, I suppose. We will listen. You have questions at the end of this session, you can ask. Actually, my topic is honor-based violence, awareness, and recommendations. I think word itself saying some meaning for you all. We'll see what the definition of honor-based violence and crime. Violent crimes or other forms of abuses are that carried out in order to protect so-called honor of a family or community. I don't know how to say it singular, but in Tamil, it's called kauram. So it's a crime that abuses that have been carried out to protect the family kauram, that is honor. So most often affected victims are females, which include daughters, wives, and sisters. Men and boys are less common victims as well. So, what do you mean by definition of code of honor? So, it refers various rules and regulations which set by the male relatives of men of a family. Most of the time, but they are linked by females as well, who predominate in their family. So, for example, they say we get married a person within our family, within our caste, within our relatives, or like that. So, whoever overrules or break this rule, they think that is shame for them. So they are losing the honor within the family, in the community. That's the meaning of that. So today's topic is that. Very interesting. So these acts are committed primarily to avoid the shame and restore the honor. So this is simple explanation. But I thought up to now, the male and female relatives set rules and regulations like code of honor. Whoever overrule that, they feel ashamed to them. They are going to lose their honor. So what they are doing so many violence to the victims. They kick the victims, scold the victims, and like they tie and keep in the house. All these things they do. They expect some sort of changes on victim, mostly in girls. So they correct herself, and they think their honor is restored. So no more problem. So it's not achieved. They plan killing the person. That is what honor-based killing. So then they think by killing the girl or the victim, they restore the honor. So this is honor-based killing. So what are the violences? This is against women and girls: domestic abuse, rape and sexual offences, human trafficking, female genital mutilation, forced prostitution, child abuse, and pornography. In addition, the honor-based violence and forced marriages also one of them. But in the honor-based violence and forced marriage include all these violences as well. So, what are the reasons for honor-based punishment and shame? Being too westernized. This differs from family to family. Some families expect you should be very westernized. Some families expect you should not be westernized. Then vary families to family. So, being too independent. So, using social media, not being obedient enough, disobeying a custom of heart, refusing arranged or forced marriage, being a victim of sexual assault or rape, becoming pregnant, or giving birth outside marriage, like that. There are so many things. So there are other reasons: separate or divorce, start a new secret relationship, talk to an interested person, refuse to wear additional garments, clothes, have relationship outside of particular regions, have sex before marriage, marry a person of their own wish, attend college and university. Some people, they don't like to send the children to college or university. So they feel that they will lose the honor. Okay. So forms of honor, what are the violences they do on the victims? Forced marriage. The child, that girl, for example, the victim doesn't like to marry this person, whatever they propose, but she wanted to marry a person that she likes, but the family think they should do whatever they want. So they overrule, they force this girl to marry. Okay, this is forced marriage. Domestic abuse and physical assault. Sexual violences and harassment, forced marriage in their own places. Forced abortions, forced pregnancy, female genital mutilation, social isolation, rejection, emotion abuse, maltreatment, not being allowed access to their children, house arrest, curtailment of liberty, no access to education. In addition, they do various other things as well, no access to telephone, internet, passport, abandonment, isolation from friends and family, starvation, poisoning, threat to kill, and murders, abuse, acid attack, kidnap, taken overseas, subject to black magic or spiritual abuse, all these things they do. So, out of this violences on victim, I want to discuss a female genital mutilation. This everybody knew. Actually, female genital mutilation is abuse according to the violence against women and girls. But it may be as seen as a vulnerable thing in some communities and families. I tell this, I think they celebrate having this. But its prime motivation of this action is to control the woman's sexuality. So it is a crime. So that you can see there are 4 types. Female genital mutilation for your interest. One is clitoris, they are cutting. Then clitoris and labia minora, then majora, then they close the vagina. What is that? This is, they wanted to control the sexuality of the girls. So because they have some fear that this girl might end up being more sexually active and have partners, and that will affect our family, that will affect our honor, and we will feel shame. So that's why this. So although it is honorable thing for some community, it is defined as it's a crime to that female. Okay, and second is a forced marriage. A girl or boy, when they are 18 years or more, may be forced to marry a person who is in that group. Then they apply for visa. If they have indefinite visa, then they are happy. Then that girl will not come back here. So victims are forced marriage are subject to all form of control and abuses in order to prevent revoking the sponsorship. But once the spouse is ILR, indefinite leave to remain, then abuse may be escalated violent. And also, most forced marriages involving British girls and women take place overseas, with the victim taken to abroad for ceremony where they marry. Then that girl will be used as domestic violence slave, the daytime, night as a sexual slaves. So this is a crime on girls as well as mainly girls, not most of the time girls. So laws related to the forced marriage and criminal offences. There are several in abroad. This is UK Antisocial Behavior Crime and Policing Act 2014. Here under section current 20 of 2014, the maximum penalty of breaking the forced marriage. If somebody attempt to force breaking the permit, then maximum penalty is 5 years. If the person can be forced to marry via legal or religious marriage, then penalty will be that 7 years. So then they find that forced marriage unit, there's a unit of support and help the victims. Honor-based killing. This is honor-based killing are the most severe form of honor-based violence. Degree of abuse and violence of the woman subjected before being killing is very severe, extreme. Women have been killed by buried alive, shot dead, burned, smoked, stabbed, stoned, and strangled, made to suicide. Ultimately, they see worldwide majority were being killed by the families of the woman. Families of the not other people. Only 7% so victims are male. Rest of the females. Okay. Most of them murdered female are victims, usually perceived as a men who were unacceptable number of reasons. Because men they say this man is good not good, that good, and various offenses on him. And when he is alone, they will do anything. They will not attempt to kill him. Okay. So they kill when that person is alone. If they are with the crowd, they will do that. Okay, that is the thing in the case of boys. So one of these killing is a planned one. It has 4 characters. Killing planned and carried out to member of the victim's family of birth rather than the family of marriage. Okay, it's the same family. For example, one kill that means from my family. not from my marriage. Okay, I am the victim, say that I will be killed. That means planned by my family, not from other. Okay, and perpetrator usually doesn't act alone. He won't act alone because honor is restored not for the individual, not for the family as well as community. So he will not act alone. And also suspicion is usually enough to kill the patient. So if somebody said that girl is connected with other person, they don't want proof. Immediately they try to harm this girl or try to kill. That is enough. Proof is not necessary. They don't want to attempt to prove. Okay? A voluntary killing is a premeditated. It's a planned organized crime rather than a crime of passion. This is a true. I am going to tell the true story. It is in the internet and everywhere. Vanna's mom, a 20-year-old girl, was strangled in January 2006. The body buried in a suitcase in Birmingham because he has left the violent husband with her boyfriend. This is the reason who has killed this girl. The father and uncle killed her. They shot almost like killed the girl and buried, but they couldn't find the body as well. Actually, this is the BBC report in November 2010. Okay, then other story. Ulen Gore, it's a 15-year-old girl, school-going girl, she along with a boy to live with a boy. So they killed this girl because his boyfriend's age is twice the age of this girl's age, and also she is from different branch of Islam. So these are the two reasons they killed this girl. Actually, the father kidnapped this girl, dragging this girl, tying up and killed this girl. Own daughter. Okay, then for that he was jailed 22 years in 2009. But he remains equally believed to be buried in the garden, family garden, but it was not found until now. Okay, these are two. What is culture, religion, and law in the case of honor-based killing? So there are two examples. Although we think arranged marriages are part of the accepted thing, but it should be accepted by the girl. But sometimes it is not accepted by the girl. They force to men. Okay, but most of the religions are not accepting it. Okay, then female gender mutilation. I said earlier, although it's the honorable thing for some communities, it's a violent crimes against the female. Okay, international laws are gradually changing since the knowledge of gender-based violences are increasing. Even with this letter, your knowledge will go up and there might be more reporting to us, I suppose. Okay, in Jordan, usually earlier, they did allow reduced sentences. If it is honor-based killing and sentences are very low, then they right to show everything as honor-based killing. Now that court is rejecting that they can't say it's a honor-based killing. Okay, that's an example. But it's a police opinion about honor killing and murder. So police doesn't want to label a murder as a honor killing. Why? If they label as a honor killing, what is happening? They right to the perpetrator right to escape. Telling these reasons, they say this is a license for their culture. In fact, a cultural excuse. They say it's a cultural excuse. For our culture is not accepted, so I will kill. Second, for those they think it's a brave act. Killing a person is a brave act. Saying that honor-based. Second. Then while police arrest him, then they send the media because it's a honor-based killing because that victim did this. So they think they are very proud of them. For these reasons, actually, honor-based killing, they don't label as a honor-based killing. They wanted to label as a murder. Okay, they want to give more punishment to the perpetrator. Shame, book Shame. Actually, it's published by, I think, interesting. You all have time. Once your exam is over, you can read. Shame is first published in 2007. Daughter of Shame published it by Jasmine the Sankira. Actually, over this part of our. Actually, she has described the own story, what has happened to them. Both of them describe their own story, what has happened to them. And also stories which has happened to their other girls important to get because this Jasmine the scientist used has a charity which help and protect girls and involve people, mostly girls, involved in victims. As a honor-based killing or honor-based they report, they identify, she gives support to them. So her work has been recognized as an important thing in 2014 in UK. This is a picture of the scientist. See, these are books, Shame and Thought of the Shame. There are so many books she has written with the name of this. So we'll see some statistical data. It's a global, often hidden problem. I think most of you all know today. I mean, no? Am I correct? So what is, several people ask me what is honor-based killing. Now everybody knows honor-based killing. It's like a child abuse. It is categorized as child abuse in Sri Lanka as well. So when you all have this problem, when somebody report you all should report to the relevant authority, that is Child Protection Authority in Sri Lanka. Okay, reported cases are likely to be iceberg, tip of the iceberg, that everybody knows. In 2000, United Nations, there are 5,000 honor killing every year, mainly Middle East and Asia. This is the thing, it's underreported. It's more than that. See how much victims, especially females, are killed. So honor killing accelerated significantly over 20 years period from 1989 to 2019 because of the reporting and internet. Before that, it was not reported. There were more incidents according to the main essay. So in UK, there are so many. This is actually a little more details. They also recorded through the Crown Prosecution Services and Forced Marriage Unit. There are 2 units. They reporting all these things. They punished and they have complaints and all these listed in this system. Incidents of forced marriage in UK in 2019, 1,507 cases reported, which is 13% increase from 2017. Actually, this is because they have launched and conducted home office communication campaign regarding the forced marriage. Then everybody come up with a problem and reported. Then they had a lot of cases and they did this statistics. So when we see, so reported cases, reported incidents of forced marriage in UK. See, below 18 is more. Obviously, the younger the age, more the victim. So then the age is increasing. So forced marriage stance is also less. So reported in below 18. Women reported more than men. Okay, this is a statistics. If they have analyzed things non-UK countries, this is for interesting. Pakistan is the highest. 687 in 2018. Post marriage. Okay. There was a research article about honor-based killing. Indian Journal of Women and Social Science. It was published in April 30, 2020. For the shape of family and tradition, honor killing in India and Pakistan. 2 countries they have studied. See the interest. What are the motivations for honor killing? What are the motivations? What made to kill them? We analyze 55% of them. That's the reason. Premarital romantic relations. We are in India. India doesn't accept that. 41% married outside the family because of the caste or class, as I mentioned earlier. When we come to the Pakistan, so 24% attempt to modernity that they don't like. So they have done 23% is married outside the family. Okay, see, it's a very interesting again. Then, who are the perpetrators? Who did this? In these studies, you can see in India, 44% is a father of a girl woman. Father did this. He is the one who killed. When we come to Pakistan, 40% multiple male relatives. Actually, they have various gangs in their countries. Using that gang, they kill the victims, girls. Okay. So there's in India, I found an article, actually, practice of honor killing in the early Buddhist society. By Darshini Ratnavali, she has published an interesting article and in stories also. You don't have time to read about that. It's very interesting. Now, no time to explain that. Actually, very interesting. read about that. It has been there in Sri Lanka as well from the beginning. Okay, it was a hidden problem which was not reported to anybody. And in future, after these lectures, I think there might be more reporting. So up to now, I have done. You can look at this diagram. Motivation behind the order based killing to avoid shame and restore the honor. So they do the violences. They expect changes in the woman. If they changes occur, then they restore the honor. So if changes is not there, they couldn't find the changes, but they try to kill the girl or involved victims and achieve the honor. So what is our duty? Up to now we have seen this. We have to do title. We have to recognize and protect the child. Now we are going to recognize the victims and we are going to protect. That's the next word for us. How to recognize? Recognize warning signs of honor-based abuse and forgery is a one chance rule that everybody must know. You can see that there may be one chance to speak to victim, and thus but only victim come and say, I have this problem. If you don't act immediately, next time she won't get a chance to report it. Next time we won't get a chance to save this life, because if somebody comes to know that she has reported to us, now they will do some sort of violences and kill them. Can you understand? The one chance rule. This is very important for us. Everybody should know. That's why when somebody brought this problem to you, immediately you have to act, and within few hours you have to save this. You have to make arrangement to save this life, save this girl. Okay, it has been there in UK, but in our country, I tried to find out, but I couldn't see. But Child Protect knows that we will do that, but it is also, I feel that it takes little more time. Okay. So, recognizing the warning signs of honor-based abuse and movement, you understand through person and professional working with girls and young groups should know this. And also all the practitioners working with victims of honor-based need to aware the one chance rule and training for all professionals about this. This is important to identify the honor-based violence. We see the warning signs of and red flag signs of honor-based killing. Educational, personal, crime and family. There are 4 factors and it will disclose. You disown again. We will see one by one. Another educational effect, absence from sudden absence from the school. Good. Long leave. Parents are requesting long leave. Why is that? This is a school going girl. Why they are requesting? Then we not told we have to suspect. Work behind. Like that, children fear that, you know, while going to school, children are, when the holiday comes, children are so fear. They don't want to face the holidays because of some reasons. So these are the reasons. So you can go through. Parents refuse permission to schools. Public being prevented from pursuing further education. Sometimes they stop schooling. So you have to think of why they are stopping from the education. So something behind that. Okay? Yeah. Education, personal control. Significant changes in behavior, for example, isolation of withdrawal. Child is usually she is okay. Now, but sometimes we have exercise is very isolated, not talking to the school friends and all that. You have to suspect. That's a one suspicious. Okay? Deterioration, appearance of and changes in self-esteem, running away, going missing. Sometimes you get missing from school. Sometimes it might be due to this problem. Honor-based violence. It could be due to honor-based violence. Or eating disorder. Sometimes they have eating disorder. They don't want to marry a person which is proposed by parents. So she right to starve. Okay? Lose the weight. Okay? All these things. So criminals, domestic violence within the family. So we can get this family always now fighting among them, some problems we have to suspect. So child come and say that at home that they have a violence. So you have to suspect. Why is that? So child also will be affected by that. So you have to investigate it. Then you can come, not always. Sometimes it might be due to the honor-based violence. Family, sudden announcement of education. So Suddenly, this is, I think we see a lot of cases. Suddenly they say tomorrow, girl is going to UK for the wedding. Why? Might be, she must be having some affairs here. Parents doesn't want to do that. Parents wanted to take the girl secretly. They do passport and everything secretly. Wanted to take the girl immediately. But this has happened to several families. I know now when we think that this is unabased violence. Okay, this type of forced marriage. So how to safeguard the children? Safeguarding children is your responsibility. Actually, safeguarding is everyone's responsibility down with the statutory guidance working for the 2008. Then they modified that. The other one is everyone has a duty to action to safeguard children as the welfare is a paramount. That's a Children Act 1980. In 2014, this act was updated and they think but for young victim of honor-based violence is a form of child. That's what I said. It's a form of child abuse. So in our country, although it is not labeled, child protection authority is, I think it's a should have the responsibility of this. They are reported when you have them. So children are also protected under United Nations Convention on Rights of Child. Every child gets rights whenever they are, whatever their ethnicity, gender, and religion, language, and all. This is their first. And child and adolescent mental health services also in UK protect from these violences. The interesting thing that education facilities have significant role in recognition. For there's an example here, you can see school nurse have a key role. In other countries, they have the phrase school dental clinic, like that school nurse is also there. So they can in supervising again. In addition to that, there was one case, you can see this case, that came to the light to the disclosure made by the nursing. 13-year-old girl complained she want a place in nurse's private place to stay. Okay. Then the girl has reported her father has removed her bedroom door in response to the dressing in more westernized way. She is dressing in a westernized way because of that. Father doesn't like. Father is thinking, showing his interest to the boys. So the mobile service in the bedroom. They kept their mobile phones also to supervise what she is doing, whether she is wearing in a westernized way, whether she not also. So to find out whether she has connection with some other person. Can you understand? So that girl is then now disturbed. So she went to school and complained that nursing officer, nurses, school nurse. So in our country it is not there. So it is the one chance rule that immediately what that nurse should report immediately the same day they should protect this girl. Anyway, this is a one chance rule to protect the girl. There are several sources to watch. Relationship of sex education in 2020. From 2020, it was introduced in UK. So they won't take an allow, but people can withdraw their children. This is good. This will put some sort of awareness regarding the sex and all these things in the school. And the printed leaflets and posters, the public places, then people will read and find out this, whether something happening to them, whether it is related to this or that. Okay, the information of details about support charities, they publish in the magazines and publications. Then whenever they read, they can find out how to report and all these things. Campaign such as when is a spoon, not a spoon. This is very interesting story. Then you can report the UK police as well. We'll see with both participants. Sometime back, this one can't do every day. So they have introduced a school is attempted to tackle forced marriages by handing out spoon to urge students to hide the spoon in the underwear. You know that when the girl is taken to abroad for the forced marriage, so one country to other country. So the Sri Lankan girl is mother is wanted to take this girl to UK, okay, for the forced marriage. She is sending. So that girl should keep the spoon in the underwear. So what will happen? This will be detected at the airport. So they find a spoon in the underwear. So that will say this girl forced to marry. Okay, that's why this girl is taken to abroad to force. She was forced to marry. Then they have detected several cases, but this one can't do every day. They have to change the items. Then this was done in one school. There are examples of charities as well, various charities. So that's the last one, practical points. Upholding family honor and avoiding shame is seen in some families as more important than life. Okay, access to information and education key to engaging girls to make their own choices. The family must not contact a witness if this is suspected. You should not call the family or anybody. So no family member should be used as an interpreter. No medication should be attempted to. No mediation should be attempted or take place. Third one, the most element of investigating honor-based abuse is safeguarding the victim from harm and consequence immediately. Okay, reporting honor-based abuse openly is a life-changing event for the victim. Many who leave the family will not be able to safely enter their lives again. They can't go back to the family. They come out of the family. So that I think there are charities which will help them to continue their life. Okay. Then all practitioners working with victims of honor-based violence need to be aware of funds transfer. Okay. So these are the references. These are the further references you want to read. This is a girl actually protected from honor-based violence. I just put like he's with a smile face. He saved her from hospital. That's the end of the story.
Thank you, Dr. Vijay, for that important presentation. Our last speaker is Dr. Sumudhu Senevaratne, Senior Lecturer in Pediatrics, University of Colombo. She will speak to us on current recommendations for the management of diabetes. Over to you, Dr. Sumudhu.
Good afternoon, everyone. Thank you very much, Dr. Roshan, for those kind words of introduction. And I would like to start by thanking the organizing committee for giving me this opportunity. So over the next half an hour or so, I would like to quickly run through management of childhood diabetes. This is a very vast topic, so I will have to go through quite quickly, and please bear with me. I will try to do my best. So all of us are aware that type 1 diabetes in childhood is a lifelong chronic disease condition which has a major impact on the life of the affected child or teenager and the family. And if you take all the diseases in the world, type 1 diabetes is the disease where the amount of patient education and involvement is the maximum out of any disease in the world. So a big part of our management as the pediatric community includes education and supporting these families. So what I'm going to talk to you today are things that I hope you will also share with young people with diabetes and their families, because empowering them is the final pathway of good diabetes care. Now, I am basing my presentation mostly on the NICE guidelines published in 2015 and updated in 2020. And the first statement that they start out is something I think very meaningful and important to all of us, that young people with diabetes have the right to be informed, involved in discussion, and to make informed decisions about their care. So everything that we know, most of it, we will be educating them and doing joint decision making. So during my presentation, I will briefly talk about presentation and diagnosis. There's nothing very new in those factors. there have been some updates and debates about management of diabetic ketoacidosis in the recent past. So I will talk about that very briefly. And then we will look at the longer term therapy, including insulin therapy, patient and family education, and long-term care. So we all know that the typical features of childhood diabetes, and indeed diabetes in any individual, be it child or adult, would be with the classic symptoms of polyuria, increased urine output, thirst, with or without recent weight loss. And recently, unexplained tiredness has also been added as one of the classic features, or one of the main features that people would complain of. But the typical features would still remain polyuria, polydipsia, and weight loss. So if you ever come across a person who is complaining of, unexplained weight loss, tiredness, especially weight loss in childhood is very uncommon. So please ask them about any increase in their thirst or urine output, and think of childhood diabetes, because suspecting childhood diabetes is the most important thing that we can do, because early diagnosis will really enhance this whole journey for the patient. So if you suspect, please suspect diabetes if they present with any of these features, and the diagnosis is pretty straightforward. The diagnostic criteria are the same for children and adults. It's the same irrespective of the type of diabetes. So this criteria would pertain to type 1 diabetes in a child and type 2 diabetes in an adult, and vice versa. The only exception to the diagnostic criteria is in pregnancy, which is not relevant in this situation. So these are the tests that we can do. So I'm talking about a child presenting with the classic symptoms. So you can do one of these tests, fasting blood glucose, a 2-hour post oral glucose tolerance test, or a HbA1c. We can also take a postprandial or a random blood sugar. And so if the fasting blood sugar is more than 126 milligrams per deciliter, or a random or 2-hour post glucose blood test is more than 200 milligrams per deciliter, or HbA1c is more than 6.5, any one of these biochemical parameters is enough to confirm a diagnosis of diabetes mellitus in the presence of the classic symptoms. So very straightforward. And please make sure that this is a laboratory blood sugar. We do not diagnose diabetes by a capillary blood sugar. So it has to be a proper lab blood sugar level to in a serum sample. So once the diagnosis is made, what is recommended that any child with suspected type 1 diabetes is referred to a specialized diabetes team on the day of diagnosis. So this is mainly, I'm talking about patients without diabetic ketoacidosis, where if you're thinking it's a child with type 1 diabetes, definitely it's better to discuss ahead with the diabetic team and maybe start the treatment. But it is good that the initial encounter is with the specialized diabetes team. This is based on the NICE guidelines, because I think this initial rapport building and counseling is very important. Of course, you can definitely continue to provide shared care once the initial counseling and management plan is set in place. So there are several reasons why this is recommended. So one of the things, especially in our context in Sri Lanka, is that as an South Asian country, we are seeing a rapid surge in type 2 diabetes in children. So 20-30 years back, if anyone below the age of 15 presented with diabetes, we would only consider type 1 most of the time. But today, we are seeing 10-year-olds, 12-year-olds with type 2 diabetes. It's a recent phenomenon, and it's very, very it's very a serious thing. And so any child, we have to also think, could it be type 2, especially if they are obese, if there's a strong family history of type 2 diabetes, if they have acanthosis at the onset, then we may need to think, is this a child with type 2 rather than type 1? Even in prepubertal children, we are now seeing type 2. The other thing is, as you manage the child over time, after the honeymoon period is over, maybe after the first year, you see that still the child's insulin requirement is pretty low, that is less than 0.5 units per kilogram per day. Then retrospectively, you may think is type 2, because it's very important for these families and these children, because type 2 can be managed by oral hypoglycemics, whereas type 1 means lifelong injections. So it's important, especially in a South Asian context in Sri Lanka, to just have this in the back of your mind. But however, this is according to the NICE guidelines in UK, they do not recommend routine measurement of C-peptide or diabetes-specific autoantibodies to distinguish between type 1 and type 2 diabetes as a routine. Of course, in Caucasian populations, type 2 is less, so they suggest suspecting type 2 in Asian people. So whether this is relevant to our population is debatable. And they say consider these testing only if the type of diabetes is in doubt. That is what we also practice. If we are not sure whether it's type 1 or type 2, we would sometimes go ahead and do the antibody testing. It's only done in the private sector, so it comes at a big cost to the family. C-peptide concentrations have better discriminative value later in the disease course, because as the in the initial phase might be a little bit difficult. So antibodies are probably the best thing in the first stages at diagnosis. Later on, maybe 1 year after the disease, if you're not sure whether it's type 1 or type 2, then C-peptide would be a better measure. Of course, C-peptide and insulin levels are now done in the government sector, so you can consider it, realizing its limitations. Its discriminative power is not 100%. And the other condition that we sometimes suspect is in a very young child below 1 year of age, especially in every child below 6 months of age, we think that this could be monogenic diabetes. Also, it could be MODY, another form of monogenic diabetes, if there is a very atypical disease behavior, or if the child's clinical characteristics are different to what we would expect either from a type 1 or a type 2, or if there is kind of atypical diabetes with a very suggestive onset in two previous generations. In those situations, you may perhaps consider genetic testing, which has to be done from outside the country. But most of the time, we will be dealing with type 1 diabetes, especially if it's a young child below about 10 years of age. Now, the other reason that I told you is very important to make a good rapport with the family, because this is the start of a lifelong journey. So if this child is going to be co-managed with a specialized diabetic team and a regional pediatric team, I think it's important for this family to build a rapport with both teams. And what we do is we commence educating and empowering this family right from the start. So it's the start of this journey is very important. Remember that we have guidelines, we have algorithms, but each patient is individual because this is their life. And as I told you, this is going to influence every aspect of their life. So we have to individualize these plans to their age. So a toddler and a teenager, they need different sorts of care plans. We need to tailor it to the level of understanding. So if we have very educated parents and a very cooperative child, maybe the level of care and responsibility we hand over to the parents and the family could be less than if it was maybe a dysfunctional family with less comprehension, lower level of understanding. So then we need to take more responsibility. So it's very individualized. It depends on the social situation most of the time, as well as the personal preferences also need to be considered. For instance, what sort of insulin injecting device would the family prefer? Those things we have to consider. So the another thing that I wanted to talk to you very briefly today is about diabetic ketoacidosis. So this bit is mainly on us, the medical team, not so much on the parents. But if we find a child with diabetes who is having any features of DKA, then that is a pediatric emergency. So the features of, if a child presents with features of abdominal pain, nausea, vomiting, of course, these are common presentations of acute gastroenteritis, but if you have a history suggestive of polyuria, polydipsia, and weight loss, then please do a capillary blood sugar. If a child is dehydrated, hyperventilating, and having a reduced level of consciousness, then the urgency is more. So these are the classic symptoms of diabetic ketoacidosis. And if you suspect diabetic ketoacidosis, and this is mainly for outpatient care, maybe general practice, please refer this child immediately to a acute pediatric care facility here, a unit with a pediatrician, because you can't be telling them to go to LRH. This is a medical emergency and the child has to be stabilized. So at the pediatric care unit, of course, we would do a capillary blood sugar and the urine ketones. The most important thing to diagnose diabetic ketoacidosis would be a capillary or venous blood gas. So the center should have access to a blood gas machine. And if the pH is less than 7.3 and the bicarbonate is less than 15 millimoles per liter, then in the presence of diabetes, we diagnose diabetic ketoacidosis. And we grade the severity of the ketoacidosis by the pH and bicarb values. So below 7.3, we diagnose DKA. If it's below 7.2 and the bicarb is below 2, then that is moderate severity. If it's more than that, that's mild. And if the pH is less than 7.1 and the bicarb is less than 5, then that is severe DKA. Severe DKA is a serious condition, and it is recommended that you liaise with an intensivist or a senior experienced person in managing severe DKA. Mild to moderate DKA can be managed in a ward setting, in a pediatric ward setting. At the same time, it's good to do the serum electrolytes, blood urea, and the creatinine levels. Any child with diabetic ketoacidosis, once you diagnose it, it has to be informed to the senior clinician, the pediatrician. If this is for the trainees, please inform the consultant and start explaining the condition to the family. I'm so glad to see the recommendations having this. This is very important. We have to start the conversation at the initial stage. So ideally, patients should have one-to-one nursing care during the DKA, either in a pediatric ward setting or in the high dependency unit. So it's important, if the child has a reduced level of consciousness, to protect the airway, keep the child nil by mouth. If there is vomiting and reduced loss of consciousness, very important to think of decompressing with a NG tube to prevent aspiration pneumonia. You do the basic monitoring, and this is very important. Now, this is where the controversy is. There are several guidelines and several changes in the guidelines on fluid management in diabetic ketoacidosis. So this actually came about in 2018. There was a randomized controlled clinical trial which looked at 4 treatment protocols. And that has been published in 2018 in the New England Journal of Medicine. I have the reference at the end if anyone is interested. And based on that, they found that our previous fears were not so justified. So this was only, this is one study, but what they found was initially we used to be very cautious with fluid therapy, but they found even with more rapid fluid, the incidence of cerebral edema was not that much greater. So the prognosis was the same for both groups. So based on this, some of the guidelines have changed. And so now the current guidelines, this is the NICE guidelines 2020, say that if the patient is in shock, give 20 ml per kg of normal saline as a rapid bolus. This you don't need to take into account for the fluid management even. This is shock, but remember, shock is rare, right? So, and how do you diagnose shock? If the patient has low blood pressure, hypotension, and a very weak Freddy pulse, then this is circulatory shock, and we give the bolus, rapid bolus, 20 ml per kg. Now, previous guidelines some decades ago said never bolus, but now that has changed. If in shock, circulatory shock with rapid pulse and low blood pressure, go ahead and give a bolus. However, remember that most of the features of diabetic ketoacidosis could be just due to dehydration. Now, if you have a prolonged capillary refilling time, tachycardia, tachypnea, don't take it as shock. That is just features of severe dehydration. In that situation, the recommendation is to give normal saline 10 ml per kg over 30 minutes. Initially, it used to be over 1 hour. Now they have reduced it to 30 minutes. So in an acute setting, you suspect diabetic ketoacidosis, check whether the blood pressure and the pulse are okay. If it's okay, then you can start this normal saline 10 ml per kg over half an hour. And this bit we need to calculate and adjust from the fluid quota. So in mild to moderate DKA, they recommend taking 5% of the deficit, 5% of body fat as the deficit. That is, when we do fluid resuscitation or fluid replacement in diabetic ketoacidosis, we do it very gradually over 48 hours. And so for mild to moderate DKA, you can calculate as the fluid deficit as 50 ml per kg. To that, you add the maintenance for 2 days. That is, all know the holiday SEGA formula, you use that and multiply by 2 to take it for the 48 hours, add that to 50 ml per kg of fluid deficit. And if you have given the first bolus, if the patient is not in shock, then you subtract that and you divide by 48 to get the hourly fluid infusion rate or the volume. And that should be given as normal saline, adding potassium chloride to the infusion fluid. So 20 ml per kg per 500 ml bottle. If the child is passing urine and you can trace the potassium, it's not high, that is less than 5.5, you should start the potassium routinely. We should be starting it unless it's very, very severe and you're suspecting acute renal insufficiency, you should start it. Now in severe DKA, they are suggesting giving 100 ml per kg, but it may be given over a longer duration. There is higher risk of diabetic ketoacidosis, so it's better to discuss with intensivist or a senior pediatrician. So that is the fluid management for DKA. And 1 to 2 hours after you start this fluid, you should start the IV insulin infusion. Now, previously we used to always start at 0.1 units per kilogram per hour, but the current recommendations say you can even consider 0.05, half that, as the starting dose. I usually tend to start 0.1 units per kilogram per hour in my practice. Right, and then of course, all this fear is for cerebral edema, so we need to monitor for that. And remember, as you start the insulin infusion, your blood sugar should come down gradually, not less than 100 milligrams per hour. And when it falls to below 250, we have to add dextrose to your normal saline to make it into to make a 5% dextrose concentration with the normal saline and the potassium. And if it falls below 110, then go up on your dextrose concentration, maybe to 7.5% or 10%. Keep the insulin infusion and the fluids going until the child is alert, looking well, no nausea, able to take orally. That means the ketosis has resolved. And you can confirm it by, if you want, by taking a venous blood gas where the pH will be more than 7.5. This correlates very well with the clinical condition of the child. So if the child is up, saying he's hungry and looking up and alert, then very likely the diabetic ketoacidosis has resolved. Till then, please do not stop the insulin infusion nor the IV fluids. Keep the child nil by mouth until the ketoacidosis settles. When the ketoacidosis settles, the emergency situation has stopped. So you can start giving the child oral fluid. It doesn't matter if 48 hours have not passed. It's very unlikely that it takes 48 hours for the ketosis it's possible it can resolve before that. So then your IV fluids can stop. The child can start taking oral sips. And if the child is tolerating that, then we can decide to stop the insulin infusion. So we calculate the subcutaneous insulin dose, what you're going to give it to the child, tell the child to eat half an hour after the subcut insulin injection, and then stop the insulin infusion about 1 hour after you give the subcutaneous insulin. After that, your diabetic ketoacidosis part is complete, over. And in the meantime, please remember to update the family regularly about the progress of the child. So this is a very life-threatening and very stressful condition for the family. And immediately after this, they have to start their journey learning all about diabetes. So, that rapport building starts from this stage. Then what do we tell the family about diabetes? So this is what I usually do. I start telling them all the positive things by telling them the positive things, that the child can have undisrupted education. The child can go to school, he can do whatever sports he was having, he can marry, have children, live a normal lifespan with proper care. So because it can cause a lot of fear when we say we're going to need injections. So we also say the positive things: with proper care, this child will have a normal lifespan and be able to do any job, marry, have kids, the important things that parents worry about. Also the child, please tell the child as well. However, it is a lifelong disease which cannot as yet be cured. There is no cure for type 1 diabetes yet. And there is a lot to learn, but it will get easier over time. Also, type 1 diabetes is an autoimmune disease, so it's important to tell the family that it could never have been prevented. That is also at current state. Even if we suspect, we cannot prevent this. So it is not, they don't have to feel guilty. There is nothing that they did wrong to cause this disease. There are some myths in the community, so it's very important to get these things out of the way. And then that it is going to be the start of teamwork between the child, the parents, the doctors, nurses, the other siblings, school, everything. We all will help this child, and sometimes they may benefit from psychological support. If they are very distressed, you can refer them to psychological counseling. I am really behind time, so I'm going to go a little bit fast now. So there are various modes of delivery of insulin and dose adjustments, and the family will need to know how to, the timing, the techniques, and the dosing of insulin. They very important that they are taught how to detect and manage hypoglycemia. They need to know how to make healthy changes to their diet and physical activity of the child and the effect it has on this diabetes control. They also need to know how to monitor the blood glucose at home using using a glucometer, how to maintain these records. And we need to tell them why we are doing this, especially the child, why it's important to do this. And they have to learn about sick day management. So there's a lot they have to learn before discharge. So on average, family would stay at least 3 to 4 days in hospital once the DKS has settled, to learn all this and become competent in blood glucose monitoring and injections. It can vary between about 3 days to about 7 to 8 days. In Western countries, sometimes they have community care services where they can go home and come, but in Sri Lanka, we don't have such resources, so we always admit them. The insulin therapy, you all know, we have the conventional premixed insulin, which is the combination of short-acting and intermediate-acting, and we now also have the multiple daily injections using the basal bolus regime. So in 2015, what is recommended by the NICE guidelines is to start offering both options to all the families. Now, in Sri Lanka, and up to now, my practice has been that I do start them on conventional therapy, and once they are fluent with it, and if they're having problems with it, with their daily routine, then we may offer them the basal bolus. But the 2015 NICE guidelines say offer both right from the start, whether it's relevant to we may not always, most centers will not have access to long-acting insulin. So in those setups, we may need to start conventional therapy. There are advantages and disadvantages of each option. So those have to be, you have to know these and discuss them with the family. And you have to consider the personal circumstances and the preferences of the family as well. And so that is why it's good for them to kind of come to meet a diabetic team and discuss all these, can come up with a plan, and then we can refer back to the local hospital for continuation of care and perhaps shared care. It's also very important to explain to families about the honeymoon period in type 1 diabetes. So because usually many children can go into the honeymoon period where they can maintain their blood sugars in a normal range with insulin less than 0.5 units per kilogram per day. That is the definition for honeymoon. If it's less than that, sometimes we can even stop the insulin for a short time. Now, it's important to tell this straight away. I tell it before discharge that we are expecting this may happen, because otherwise there may be various other factors when they go back home, community, people trying to make money out of these families might say, I can cure this, these are all myths, but it can happen. And then they stop the insulin, they go for some other form of therapy during the partial remission phase, and they may actually believe this person. But over time, we know that partial remission is only partial. They will definitely need insulin to live after the first year of life. So then they may, we can even lose a child in that situation. So it's very important that we always explain this happens, and that's a normal thing. It's not that we have made a wrong diagnosis. This is how diabetes works, and it will come back. It's just a temporary phase. You have to keep on coming to the clinic and monitoring, and we can change according to what the blood sugars show over time. Now, these are the different types of insulins which are in use. Due to time, I will not have time to go through this. And the basal bolus regime is when we use multiple daily injections. So we use either rapid acting or short acting insulin before each meal. So before breakfast, before lunch, and before dinner. So they need 3 injections before the 3 main meals. And then we give usually one dose of a long acting insulin to cover the rest of the time. So this is the basal bolus regime, which the 2015 guidelines are saying you can offer even from the beginning. At Lady Ridgeway Hospital, we have long-acting insulin, and I think now the endocrinology, adult endocrine services are also getting long-acting insulin to the government sector starting from next month. So we may have more options to start basal bolus even in the regional centers. And this is what the profile looks like. If you look at the dietary management, so what I usually tell patients is this food is not toxic to the child. You just need to avoid high glycemic index foods, which will cause the blood sugar to spike. So those are things like sugar, sweets, chocolates, all the unhealthy things. So a diabetic diet, there is no diabetic diet. What we are advocating is a healthy diet. So nutrition will affect their diabetes control, and using an appropriate diet with healthy food items will help to improve their blood sugar and prevent long-term complications. We can't cure the disease, but we can prevent the other organs like the eyes, the kidneys, the nerves from getting damaged by maintaining good blood sugar control. And the keystone, one of the cornerstones of that is a healthy diet. So we have to understand what their previous diet was and help to adjust their diet to a healthy diet. And always encourage foods with a low glycemic index, which includes fruits and vegetables. You have to, however, consider social, cultural factors, the cost of these foods, what we are recommending, and remember that actually the nutritional requirements do not change when you have diabetes. It is the same as for other children. We are just stopping high glycemic index foods. Now we have to recommend regular meals and snacks if a child is on conventional insulin. This is because we are always chasing the insulin doses. So, so these families will need some basic carbohydrate counting education. So they need to know how much of carbohydrates is there in 1 cup of rice, in 1 slice of bread. So there's a book written by Professor Shamya De Silva, which is very informative, very useful for children with type 1 diabetes and their families in all 3 languages. So that gives all these. And Dr. Naoda Patu also has published a book on carbohydrate counting. I think it's available as an app also now. So these resources are available to patients. And so they have to learn these. And in a conventional regime, we have to make sure that these children eat the same amount of carbs for the breakfast, for lunch, for dinner, and have the 3 snacks in between these meals. And if they are having 2 portions for breakfast, next day also they must have 2 portions. So it can be for bread, it can be rice, but it has to be equivalent in carbohydrate content. And when we go for advanced carbohydrate counting, that is when we give them an insulin dosing ratio for the carbohydrate. So we say if you're taking 10 grams of carbs, you give yourself one unit of the rapid acting insulin. If you're taking double that, 2, triple that, 3. So like that, then they know how to adjust. So the bolus insulin, which is given with each meal, is calculated by the family based on a ratio that we calculate mathematically and give it to them. And over time, these ratios and all change. So when you are having this basal bolus regime, you don't have to eat the same amount of food each day, and you can adjust the timing when you're eating, when you're ready to eat, half an hour before you give your insulin dose. So a child who has to go to school at 5 a.m. and then comes back at 3 p.m. to have the lunch. So at 6 they have the insulin, have breakfast at 6:30. This is the rapid acting or the short acting, and then when they come back they can wait without snacks in between. They can come back at 2 and have their main meals, because they don't have a peaks and troughs as with the conventional regime. So that is the advantage of the basal bolus regime. However, they have to learn how to count these and calculate these. It's an ongoing process. So it has to be an individualized choice which is relevant to this child's lifestyle, their educational level, their ability to understand all this. So we can offer both and see, make a joint decision what would work best for this family. We don't have insulin pump therapy in Sri Lanka because it's very costly and technologically very advanced, but it is available to children with type 1 diabetes in many most developed countries. I don't think I have time to go through all this, so I will not talk about hypoglycemia. These are very basic things, nothing new. And the targets for blood glucose monitoring have been little bit, now they are more stringent. So the HbA1c that we want to achieve is now 6.5. Initially we used to say 7, but now we are targeting for 6.5, and the lowest attainable. 6.5 may be a dream for most adolescents, right? But at least try to go for the lowest attainable till that 6.5 is what we really should be getting. And in the blood glucose now, when you ask a child to monitor the blood sugar 3 times a day, we usually go for the 3 pre-meal things, that is pre-breakfast, pre-lunch, pre-dinner, because we only give 100 strips a day, even at LRH. So they have to know why we are doing it. Why are we doing it? It is to protect their other organs and make sure they can live a long, healthy life without going blind or needing a renal transplant. So they have to understand we are doing it for their health. I always tell the families that, and we teach them to read their blood sugar records. So they also see improvement and they learn to read these themselves. No point them just depending on us. It's about empowering them. So the pre-meal recommendations are now 92 to 126. So in the non-diabetic, non-hypoglycemic range, we know that a fasting blood sugar above 126 is diabetes. So we are trying to reach that ideal level, and below 72 we take as hypoglycemia and diabetes because it's an insulin kind of derived thing. So 72 to 126 is the target, the ideal target. Maintaining it at that level will give you HbA1c of 6.5, but as you may know, it's very difficult to achieve this in day-to-day life, but these are the ideal, and there are children who do achieve this. And post-meal, if you are checking the post-meal, then it is 90 to 162. And this is how we tell them to monitor their blood sugars, and every clinic visit, we teach them, okay, so look at these. Now see, this day, it's very high. What happened that day? And see, now this is a family who's actually doing correction doses. So now you can see on Tuesday, there was a 402, but the mother had given extra rapid acting 7, and it has come down to 189 on Tuesday. So they are correcting for these as well. So all that knowledge we give them. And we encourage sports. There's nothing new here, and nothing new in intercurrent illness, just to continue the insulin. And if the child can't take orally, come to hospital, start a drip, but continue the insulin. And follow-up should be done at least 3 monthly in a diabetic clinic. And very important to explain the importance of HbA1c to the child and family. I usually tell families, this is like your horoscope for your future health with diabetes. HbA1c, if you can keep it at least below 8, then you can live a relatively long life. And say it's like your O-level exam, or so if your term test, your end of year test, unless you do your monthly test marks properly, you will not do very well in your final exam. So like that, your blood sugar records are like your monthly or daily homework. You have to have it at those target levels to achieve the HbA1c. So then families and parents, they start getting on board, and so we work together to maintain the HbA1c to protect their overall health. There is suboptimal control, and so these are the things that we should do. Always check for lipohypertrophy, their techniques and compliance. And if there are, if you still there you can't find a problem, then we have to try re-educating them, additional support, and sometimes maybe we need to think of changing to a different insulin regime. Especially teenagers get sick of diabetes, they stop taking insulin, and these are, I guess, common problems. And we may need to compromise. Scolding the teenager, saying you're not doing this, fault finding will worsen the situation. It will cause undue stress, family conflict. So we may need to compromise. Because ultimately what we are trying to do is improve the quality of life and longevity of this child. We have to consider that they could be having psychological problems or psychosocial difficulties, which is leading to the suboptimal control. It's common to have these children have higher risk of anxiety, of depression. There is higher risk of having various family conflicts because of this, and they're also more prone to eating disorders. Now, especially girls, they are recognizing more eating disorders, which can cause hypos, and all sorts of things. And actually, they have a diagnosis of eating disorder, which has to be managed in liaison with the mental health services. So please consider these also when we are looking after such children. We all know about the complication screening, so I won't take much time over this. Nothing new here. We are also seeing lots of kids with type 2 diabetes now. So I thought I'll just have one slide on how it differs. So we have to have more impact on the lifestyle, and we need to keep talking about weight reduction strategies and diagnosis and each and every visit, because they can cure their disease if they lose weight. So type 2 diabetes is now a curable disease with significant weight loss. And what they are referring is now to offer metformin from the diagnosis, because it can help in the weight loss. We need to educate them on, not on insulin, but on the benefits and side effects of metformin in this case. And we need to be sensitive when we talk about eating and weight. Also, again, there can be conflict, so it is a bit of a compromise. And complication screen is slightly different, because we have to start measuring blood pressure, monitoring lipid profile, microalbumin at diagnosis and annually thereafter, because the risk of microalbumin is, these complications are higher in type 2. Eye screening can start from 12 years. In type 1 diabetes, if the recommendation is to start complication screening at 12 years of age. And then finally, transition from child-centered to adult-oriented health services also has to be considered. So ideally, it should be a planned, purposeful process which addresses not only the medical but also the psychosocial and educational, vocational needs of the child. What it means is, if a child is going to have the O-level, A-level exam in 2 months, we do not transition that child at that point. Even if he's turning 18, we will wait until his exam is over, maybe results come and he's in a stable situation before we transition. So, and what the recommendations also say is that the timing should be based on the patient's maturity, the local circumstance, and a time of relative stability in health and other life transitions when you consider time you move this child from our service to the adult service. And these are based on these recommendations. And having a proper transition will help to improve the follow-up in adult care, help them achieve better disease control in adulthood, and also to better pick up problems which may happen from moving from one service to another. And finally, insulin pump therapy is now very well recognized in high-income countries, where it uses only either rapid or short-acting insulin as a cartridge. It's like it's a little pump which is worn on the body and continuously delivers short or rapid-acting insulin to the subcutaneous tissue. So patients don't need daily injections, but they need to change this injection site every 2 to 3 days. So that is the invasive procedure they have to do. And now we have heard of the artificial pancreas. That's just insulin pump. Well, not just, it's an insulin pump which reads information from a continuous glucose sensor, which is again a subcutaneous device which measures the interstitial blood glucose, and via infrared it delivers this information automatically to the insulin pump. And in between there is a like a cell phone or an app which has a control algorithm in it. So so the child or patient does not have to decide what dose of insulin to give, or when to give the bolus. The closed system without human contact, these two talk to each other and act as a so-called artificial pancreas. It's a very technological device, and these are also now in practice in Western countries. Finally, can we cure diabetes? So islet cell transplantation has been in research for a long time now, and what they are doing most of the time is taking islet cells and injecting it to the portal tract so that it goes and seeds the liver and forms insulin producing islets in the liver parenchyma. Now this works, but the problem is the rejection is very high and needs very potent immunosuppression to maintain graft rejection. Therefore, it is still not in clinical practice because the side effects or the problems with the immunosuppression which is needed makes it not the cost benefit is no longer there. It's better, it's safer to live with diabetes than with this immunosuppressant therapy. Therefore, the way forward appears right now to be going on for more technological developments like the artificial pancreas. So as I told you, I based this presentation on the NICE Guidelines 2015 update in 2020. And for further reading, you can also look at the SPAD guidelines and the Pediatric and Child Health April issue, which was on diabetes mellitus, especially the pump therapy. The change in fluid therapy in diabetic ketoacidosis comes from this PERCAN fluid trial, which was published in 2018 in the New England Journal of Medicine for anyone who is interested in reading further. So thank you very much. I'd like to stop by reminding you again about the patient and how we need to kind of work with the patient and educate, pass on all this education to them so that they can also be involved with us in managing their diabetes. Thank you very much.
Thank you, Dr. Sumudhu, for updating us in diabetes and its management. Thank you all for the interesting presentations and patient listening. This brings us to the end of the session. We have only a limited time for any burning questions. Quickly, can we have any questions? We have most of the presenters with us. If there are no questions, I would like to call upon Dr. Chitra Vamadevan, consultant pediatrician, Teaching Hospital, Batticaloa, to deliver the vote of thanks. Over to you, ma'am.
Thank you, Roshan. Hello? Can you hear me?
Yes, madam, we can hear you. Go ahead.
Thank you, Roshan. First of all, I would like to thank President Sri Lanka College of Pediatricians and the Council and Organizing Committee for arranging this regional session at Eastern Province. I would like to thank Prof. Gorni Lianage for giving welcome address today. And special thanks goes to all the speakers, Dr. Tekla Javikrama, Dr. W.A.M. Aslam, Dr. Kavinda Jayasri, Dr. Kosala Karnaratna, Dr. Sumudu Senivaratna, Dr. Sujit Gunaratna, and Dr. Vijay Thirukumar for selecting common and very variety of interesting topics and very informative presentation today. And I would like to thank Dr. Roshan, take the responsibility as moderator and arranging the program very nicely. And Dr. Vijay from Eastern Province representative at Sri Lanka College of Pediatricians for initiating and arranging the regional session for the participants here. And Batikalo Medical Association for arranging the presentations for Teaching Hospital Batikalo viewers and technical support for the presenters from Batikalo, and all the participants who are viewing the program today actively. Thank you all. Finally, on behalf of Sri Lanka College of Pediatricians and the regional pediatrician, I would like to thank our sponsors today for the successful program, Nutricia and Unichem Laboratories. Thank you all who supported for today's program. Thank you.
Thank you, madam, and good afternoon to you all.
Unichem Laboratories. Unichem Laboratories. Unichem Laboratories. Unichem Laboratories. Unichem Laboratories.